business, and those online who are following, again, thank you for your interest in us today. With apologies from Chris Oliver, who's away, from Tracy, who's not well this morning, and Sheena Comiskey has been delayed in her travel, so will be arriving, but I'm not exactly sure when. No new declarations of interest determined. The schedule's there for the public record. We've got the minutes of our last meeting in public, which was on the 8th of November, in front of us. Any points anyone wishes to raise from the minutes of the last meeting? Are we content to adopt them, please, the record of the discussion? Yeah, thank you, Roy. And we've got the action log. So, the status of the actions on the log, integrated performance report on the agenda again today. The maternity service on the agenda today. Research and innovation will come back to us at our next meeting, Sarah. The tobacco-free Lancashire, again, also to return here when ready. The freedom to speak up on the agenda. Recovery and access to primary care progress on the agenda. And the complaints, you circulated the report. We didn't discuss it at the last meeting, but you circulated that subsequently. Thank you. Let's move straight on. Report of the Chief Executive.
Good morning, everyone. Happy New Year. Probably January, just come back from the winter break. Good time to reflect on 2023. It was a very, very challenging year. But with a challenging year, it brings opportunities to do things you probably couldn't do in normal times. Just a few highlights, not covered in the report, Chair, but I think worth just thinking about. We did finish 22-23 well financially. We agreed a major place integration deal in July. We've agreed some serious reconfiguration of community services. One item's on the agenda today. We'll have another item at our March board. We delivered the running cost reduction set by NHSE well ahead of schedule. We signed up to a 3-year recovery programme with NHS England, which will need some major reform of clinical arrangements and community services. We did a major transfer of continuing healthcare staff from the CSU into the ICB. It's, I think, something like 200 posts almost, so pretty significant in October. We've had a really strong performance again through our vaccination team for older people at risk of COVID, with easily the highest rates regionally. And there's some exciting work underway in Barrow, which we'll brief you on in due course, with all of government around the investment in the shipyards there and the opportunities for healthcare investment going forward. So I think there are a lot of things that we should be proud of there. We've just come through, and we're not out of the woods yet, a very, very difficult winter period. And I do want to pay tribute to our providers, to our local government colleagues, and to our own staff. I think we had one day for one of our hospitals in Opal 4, which was last week. But actually, there's been a lot of good planning going on that I think has paid off. I wouldn't want to say it's all been smooth. It hasn't. It's been extremely challenging with the strike action. But I'm really proud of the way that our system has coped in very, very difficult circumstances. And we did also have within the ICB a staff awards event on the 6th of December last year, our first staff awards. It was really good. We had 170 nominations. It was all around the values that you've seen. That, you know, the acronym is PROUD, Chair. It's people. It's all about the people and the patients, of course, about being respectful, about being open, facing up to the issues and being fully transparent, about uniting, working as a team rather than individuals, and working as a system with our partners, and of course delivery, which at the end of the day is the key thing. So I'd like to acknowledge the 170 nominees and the 9 winners. It was a really good day, and we need to do more of that. Thank you, Chair.
Thank you. Any questions, additional points on Kevin's report? Yes, Debbie.
Thanks, Chair. Thanks for the report, Kevin. I think it's a really balanced view. I think it's really positive that you draw out the positives as well as the challenges around the system, many of which will be focused on as we work through the agenda. So my question really is around 4.2, when you talked about the opportunities, and you mentioned that the ICB exec are launching a programme to transform care in the community. I just wondered if you could share any more detail with us, particularly around sort of timescales, focus and also ambition for that really critical piece of work for our system.
Yeah. We had a session together on the 12th of December working through who was going to do what really in that space. So essentially there are 3 programs. One is around care at home, another is around integrated neighbourhood teams, and the third is around healthy communities. Effectively, we've asked Louise Taylor to be our lead across the whole area. We are in discussion and will announce soon. It's all about resourcing it up. So we have got a senior leader from one of our trusts who will be the lead program director. So that's just being finalised now. And we're identifying resources for each of the work streams. We will have a session, I think, at the Recovery Board in February looking at what we're planning to do. And what we will do is have a development session with the board at the right time when we've got some flesh on the bones, if that's okay. But we're basically, we're getting all our ducks in a row, resourcing it up, and we think we can come forward pretty quickly with some investment proposals.
Thank you. Any other points to add? Flavour of winter pressures, Aaron?
Thanks, Chair. I'd echo Kevin's comments about the preparation and the planning that went through kind of October and November with system partners has put us in a good place through the winter period. I think the industrial action was a big challenge for us all, but checking in with the CEOs and the teams over the last week, I think 2 of our units in particular, Blackpool and East Lancs, faced a lot of urgent care pressure, including an Opal 4 escalation, but for one day whilst the partnerships kind of supported some of that pressure. I think we had some lessons to learn from the last few weeks. There's some really differential impact through the industrial action of relative performance and some of the approaches that we've taken across the providers, which we'll look to scale and share out for any future pressures. But when we look at the key measures of cancellations, safety or quality exposure and patient experience, the feedback that we're getting up to this point is that we've managed very well. Conscious that winter generally goes out to March, so we've still probably got another 8 weeks worth of pressure. But all of the providers are currently talking about some of the escalation capacity and the additional infrastructure put in place coming out of earlier than anticipated, which is a good sign of stability. So yeah, good planning, good execution, good cover from colleagues, significant pressure in the last week in particular, but I think that the measures that we're seeing back are giving us good confidence that that's the approach we deploy again in the future.
Thank you. It's very positive. I don't know if Angie or Kath or Vicky want to offer any observations. Kath, please.
Yeah, more than happy to. So I think that just to reiterate comments about the planning that was done beforehand definitely stood us in good stead. And I think from local authority perspective and social care, I think that the preparation, but also the relationships that we've got across the whole of the patch, those strong relationships between health and social care have stood in good stead. I think the challenges exist right across the whole of the community and the hospitals, but the working together is keeping us as safe as we can be and getting us through some really difficult times.
Well done, Kath. Thank you. Okay, let's move on to the rest of the agenda. As we work through, on item 9, the Blackburn with Darwin transaction, and particularly the child and adolescent mental health service dimension to that. At the time the paper was prepared, and subsequently, as you will imagine from the complexity of such an arrangement, there's lots of work going on, both in a due diligence sense and also in a planning and preparation sense. And therefore we're going to not take that paper today, pending the further work that goes on, and we'll be able to come back in due course and as soon as possible to take it. This is not this is not code for. We're not absolutely right behind Claire and the place team in leading and taking this work forward. It's a great example, and we'll continue to work with and through place to take this forward. There's great work going on, led by Claire. It's also not signal that we're getting cold feet on any of these service change issues, but we've got to be really sure-footed, and we've got to get it right, and we've got to be right on top of the issues of the day when we do it, and that's why we'll just not take that discussion this morning. So we'll go on to the patient story. Sarah, please.
Yeah, thank you, Chair. I think it's a very pertinent story today, particularly to the paper we have towards the end of the agenda on recovering access to primary care. So when you listen to it, what really brings home to me on this story, it's not really about a poor experience of care. I think the care this individual got when they finally got into a service was actually very good. It's the difficulties and the frustration of getting access to that care. And I review all the complaints letters on behalf of Kevin, and I would say in every complaint letter there's themes that are coming out in this story, particularly around access and communication. So I would just want the board to think about that as they're listening to the story today.
I contacted my GP surgery to request an appointment because I'd been experiencing stomach and back pains, hair loss, and my nails had become very brittle and started to crumble. The symptoms had begun quite suddenly over the previous couple of weeks and were making it difficult for me to carry out my job as a chef in a busy kitchen. I felt that they were getting worse, so I rang the surgery hoping for a same-day appointment on my scheduled day off. It isn't always easy to get time off work to attend appointments, and I don't get paid for being off work. I'm quite a confident person, but I always feel really anxious before ringing my GP surgery, because I often have a poor experience when trying to get an appointment. It feels like going into battle before I even dial the number. There have been times when I just haven't gone to my GP because the experience is so off-putting, even confrontational. Unfortunately, this time was one of the worst. From the outset, the receptionist was rude. I fully understand that they have to ask questions, and I don't have a problem sharing details with them, but she didn't even let me finish my sentences before cutting me off and asking another question. It felt like an interrogation rather than someone trying to get the best information from me to help. It made me feel as though I was being stupid and wasting her time. In the end, she told me that I couldn't have a same-day appointment because I didn't trigger it as an emergency. She didn't even offer me any advice on what I should do next. I was quite upset by this point and asked to speak to her manager. I was put on hold for 10 minutes, after which another person spoke to me and booked me 3 separate appointments for 2 weeks' time. One with a physiotherapist, one with a mental health practitioner, which I'd not requested but was given because I'd expressed that the call had made me anxious, and one with a GP. I was told that the GP appointment was only available on condition I attended the other 2 appointments. I didn't know what my work rota was at that point, and whether these would be on a day off or not, but I wasn't offered any choice. The only allowance they made was to book the appointments for the beginning of surgery at 8:30 in the morning. This still had the potential to impact on my work though, as I often start early to accept food deliveries for the day. Money's so tight at the moment that it hurts to lose income, especially before Christmas, and people shouldn't have to make a choice between work or health. It felt like they didn't care whether it caused me issues personally. I had to fit in with them or not at all. When the call ended, I felt humiliated and not listened to. I just really didn't feel like attending the appointments, but my family persuaded me to go with it. 2 days before my physiotherapy appointment, I got a text message to say that the face-to-face appointment with the GP would now be a telephone consultation and that the appointment time had changed. The new appointment time now clashed with the practice's physiotherapy appointment that the surgery had booked for me. It takes ages to get through on the phone, but I had to ring them to tell them about the clash. Even then, they weren't willing to offer me an alternative appointment, but instead put a note on for the doctor to say that I might not be able to answer the phone if I was in the other appointment. I don't think they appreciated how anxious this made me feel. The back pain, stomach cramps, and issues with my hair and nails hadn't gone away. I'd done everything that they'd asked me to, but I was at risk of missing my precious GP appointment. The physiotherapist was brilliant. I had a really good chat and assessment and was asked to do some daily exercises to help with my back pain. These did help a little bit, but I still have back pain now. The appointment with my GP was the start of a number of tests and investigations which are still ongoing. She took the time to listen to me and didn't just dismiss me because of my young age. I was able to tell her about my symptoms and she arranged for some blood tests and a follow-up appointment. When they came back inconclusive, she continued to support me by asking me to have some further tests. In all honesty, I've been really reluctant to book follow-up blood tests and drop things off at the surgery because I just don't know what to expect. Now that things have started to settle down for me from a symptoms point of view, it's hard to find the motivation to face a potentially unpleasant situation. I've had to take a deep breath sometimes just to walk through the door as it does feel intimidating. I'm still on the road to recovery, but I felt completely supported and looked after by my GP and all the clinical staff at the practice that I have spoken to, like the practice nurse and the physiotherapist, but just getting an appointment was difficult. Working in hospitality makes me appreciate how important that first point of contact is. It sets the tone for how people feel about their whole GP experience, and going into it expecting barriers is the worst thing. It's not right when people are put off asking for help or advice.
Yeah. It's, how did we become aware of this? Was this raised with us formally, this case, Sarah?
Yeah, well, this one, I think the patient engagement team are out and about all the time doing lots of work, so I think this was brought up in one of their engagement events at place. But it's not, a couple of comments for me, I think that's what I was trying to say. Unfortunately, it's not an unusual theme, and I spent Monday afternoon with about 40 of our frontline nurses and AHPs that work in community services, and even they were saying some of their frustrations about some of the layers we've put in, which, to be fair to the receptionists and things, we put some of these layers in to try and manage demand so that people get to the right appointments in the right place. But I think what that story there has showed is sometimes we stick to those processes and don't listen or don't respect what the person's saying to guide them. And even the frontline staff were saying they get frustrated about the layers that are put in sometimes for people to get them to. And I think the other thing for me is, even with those layers, basic kindness and compassion and respect for individuals when you're dealing with them don't cost us anything. And I think sometimes we clearly see through and through on poor communication that we lose that. So, the paper later on talks about the total number of increased appointments. I think what the story brings out, it's not just about the totality of appointments, it's about how we have the system set up for people to access in a flexible way.
Neil, David.
Yeah, I suppose I'm just left wondering kind of what the levers are that we have to try and improve the picture, because obviously GP commissioning is tricky, and what we're talking about here seems to be attitudes and customer service, actually. Remembering that we're in a service industry and that our duty is to provide a high standard quality experience for people. So I just wonder what the levers are that we have. How do we support surgeries and their leadership teams to understand that customer service is vital?
David, could you address David's point in the context of that? When we become aware of things like this, how do we, it's a matter of routine, engage back with the practice, give feedback, try and...
I'm just checking this, as it has come on, it hasn't lit up, but because I can't see it. Yes, we have got a paper later on about primary care, and I think as Sarah's highlighted, the number of appointments has increased. But nevertheless, there is that barrier sometimes to get through to those appointments. If I'm going to say one thing personally is, to be honest with you, it is a really interesting story because I've come home from work and my wife has actually shared the same story with me. So it's the fact is it does, I think, happen to quite a lot of people. It's a real challenge to get through those barriers. I think if patients are finding it difficult, there are two things we can do. The first thing is, on an individual basis, they could either speak to their practice or, of course, are the commissioners of those services. They can come to us unfortunately through a complaints process. But the second thing I think we could do is we could, from this meeting today, I know we have 192 practices, but I just wonder whether we should write out to them saying we had the patient story and reflected on the challenges that patients have with accessing what is undoubtedly good quality care within those practices. And we'll word it in a way for them perhaps to kind of consider how they can ensure that their staff, their administrative staff, are ensuring the patients get easy access where possible. And it may be something that Jeff would want to comment on as well. Thank you.
Yeah, you can't defend this. It's terrible, isn't it? And it does happen commonly. Obviously, we haven't got the GP's point of view about their problems, and we know what the problems are: the lack of workforce and increasing demand. But I don't think this requires practices to do more work. I think it requires them to do work in a different way. It's unacceptable for someone to ring up and not get a satisfactory plan. So it might not be you are going to see the GP today, but you've got to have a satisfactory plan. But this is what we're going to do. And offering someone 3 appointments is just wrong. And then changing the plan that happened to this patient. But it happens very commonly, and I think it's been a response to. I mean, let's understand this. It's been a response to unbearable pressures that have been building up for a long time. But I think we've responded to it in the wrong way. I think you've got to have a decent plan for the patient so that they're confident and that they accept that. And I think that's the end of the initial consultation. I actually think, and most of my colleagues don't really agree with me, but I think what we did in COVID and what I was doing before COVID was that I spoke to every single patient who asked to see me that day. And I think if you have senior decision making right at the very front, I think that helps a lot. It doesn't mean you don't have some form of triage first by reception, because sometimes patients ring up and say, I need to see the GP today because my parking ticket says that I've got a parking ticket, and if I can prove I'm disabled, well, you don't need an appointment for that. We can deal with that. So sometimes it's because patients don't understand the other pathways, and reception can help the patient to understand there are different ways to get what they need. But when a patient needs to see a clinician, I think they then need to speak to a senior person, usually a GP, to do the triage, and that worked fantastically for me. But as I say, it's not well liked. It's not well liked by doctors because they feel that there's more work going on them, which I don't. I think you can redirect a lot of work if you do it like that. But also, it's not liked by some patients because they feel like they're not going to get to see the GP. So there's a cultural thing on both sides of the equation, but we need to work on that with practices, and it's a training and cultural educational issue.
Yeah, thank you. I've got Angie, Jim, and Aaron.
Thank you. So this isn't a new issue, is it? And I do remember from my childhood running the assault course of the doctor's receptionist, and it's one of the fabled issues, isn't it, in our culture? So this isn't new. What I would say is, firstly, this isn't unique to GPs. And I think if we look across the whole of the health and care system, we would say the same about the hospitals, we would say the same about accessing social care. This is a challenge for all of us. And while I can see the rationale, and you can see that actually behaviours were probably questionable, but there was a definite attempt to help this individual and get them to the right services as quickly as possible. But one of the experiences we've had in local government is that our access centres don't work as effectively for people who have complex personal issues. So we're looking at whether they are the best mechanism of filtering demand, or whether we do need, as Jeff said, to take people through to specialists more quickly so that actually we can resolve the issues. So I do think this is an area where I think all of us need to reflect on what the patient has said. I don't think it's unique to GPs. And I do think there's an opportunity to share best practice so that we can all try to lift our game. Thank you.
Thanks, Angie. Very helpful. Jim?
Thank you. Jeff said one of the things I was going to say, which was pre-COVID it was different, and we don't seem to unpick what we did for COVID, and the barriers seem to be all primarily introduced during the COVID period and have not been removed, and it almost feels like they should be taken away now. So the first thing you do when you ring up the GP practice is you go through this telephone conversation where they're just talking to you for about 2 minutes basically. So you get this message that goes on and on and on and on. So you don't even get to speak to the receptionist to start with. So it feels like there should be some process whereby we could withdraw what happened during COVID somehow and just go back to simplifying the system. But putting that to one side, I keep reading about the improved arrangements that are about to be introduced from a technology perspective, whereby there won't be this rush to call at 8 o'clock or whatever it is, because technology is going to improve things. I've not seen much about that in this board, but presumably that's going to improve this situation significantly, one hopes. So people will get better access to, they won't have to kind of panic in the morning about ringing the GP practice in the same way, for example. And I'm hoping that that will improve the way in which people view this service, because everybody I speak to has a story very similar to the one you've just broadcast, which is scary, I've got to say. I don't think it's quite as bad getting into hospital, by the way. The problem is getting through the first barriers to get referred to hospital. If you get referred to hospital, it tends to be okay, but it's actually getting to the point where you get referred.
Yeah. David, do you want to come back on the point in the item later? That would be the best way. And Aaron on this now.
Thanks, Chair. So I know we have an item on the agenda later, and Kevin updated in his report the Community and Primary Care Transformation Programme. So that patient story is an example of no one in that experience having a good outcome. So receptionist feels under pressure, patient doesn't get the service they're looking for, GP gets poor feedback despite working really hard. And what happens there is we've got an overconsumption of resources, and we've got lack of clarity on who's managing which part of that pathway. So we don't often yet bring together primary care leadership and the patient voice under the transformation banner. And whenever we've done that locally, you generally get some really good local solutions of things that might work more effectively. So what I'd look to do is to give that authority and permission to primary care leadership and patient group under the transformation work stream to see if we can find some solutions to this that we can spread across, because it's very difficult to do it at the practice level.
Thanks, Aaron. That's very good. Debbie, anything you want to add at this point of the discussion?
Yeah, I support colleagues' comments. I suppose from my perspective, I'm sitting here as a commissioner. You get that personal perspective, don't you? Because we've all had it where you're trying to ring, you're desperate to see someone. It's so difficult. If you've waited 20 minutes before you even speak to someone, you're in a really bad place before you even have a conversation. So I think for me, sort of trying to see it with a commissioner's hat, it's about how we enable, and if we have put any barriers in the way, being quite open and frank around the highest quality service being delivered in individual practices. And I think Aaron's right, it needs to be almost like a system solution, because there will be some things that we've done either through contracting, support mechanisms that will get in the way of GPs wanting to deliver the fantastic service that they're there to do and that they're passionate about. So I suppose when we consider it, and we can pick it up later in the paper, I'm really keen on understanding what those barriers are. I think if we just write out to them and remind them that we want them to deliver an amazing service, they know that that's what they're there for. That's why they get up in the morning to do it. It needs to be more of a collaborative approach, actually discussing with them what are the barriers to delivering that service against a very clear view of what an excellent service looks like, and supporting them to move towards that depending on where they actually are.
Thank you. So, David, you said about communication more broadly with the system letter. I think we're pretty good generally as an organisation, as a system, of not falling into the trap of we've got a problem in something. I know what we'll do. We'll just write out and tell everybody to fix the problem, and then we sort of move on to the next thing, thinking we've done our job on this now. And we're on the receiving end of lots of those things coming through the system. I'm sure it's the same with local government colleagues as well. But I do think there is a moment when you can make a statement like that that says, "Hey, look, we discussed this at the board. There really is an issue here that's beyond one or a small number of cases," and that, and then we can back that up with something that goes beyond the "so what." We've told you not to do this anymore, in terms of a more developmental and a more structured approach in the sort of context that you've described, Aaron. But Kevin, how do you want us to move forward with this?
Look, I think that was a really moving, sobering story, wasn't it? It's a service under pressure. I think we should stand back and reflect that actually there's been a massive improvement in productivity in primary care over the period. We're getting a lot more service for actually fewer GPs. And one of the reasons for that is the investment in, if you like, the wider primary care team, all the allied health professionals that support the GPs. That's been a very significant change. There's more to do there. We do get funding streams for that, and we sometimes underspend them, including this year. That's a frustration, so that's an area I think needs attention. And as Jim said, there is an investment program in telephony to have more digital telephony and help improve that experience. We are taking advantage of that. I'm not sure what the numbers are, but they're quite significant in Lancashire and South Cumbria. But fundamentally, it's not really a technology issue. It's about those people, culture, and service issues as well, isn't it? So I think that was a sobering story, David. There's a lot to do still.
Yeah, thank you. Anything you want to?
No, I would just endorse what people say, just to pick up on a couple of the questions you raised. I think a lot of practices do customer care training, so I suppose it's making sure that that's on a rolling basis. And a couple of thoughts I had while we were talking. I think we could do more. In a previous role, we put a lot of information leaflets for patients that wasn't an outpatient setting, so that pre-coming to they knew what to expect. I think there's basics like that. And I just wonder how much primary care have thought about using volunteers, because sometimes you need somebody to help you navigate the system, and the trust do that quite well. Often we'll have volunteers who will help people navigate around the hospital, but I think it's something we could think about with the primary care team, whether there's more role in primary care for the use of volunteers to help people navigate, which I think we forget. When you live and breathe it, you forget how complicated the system is. And actually, I've used services more in the last 2 years than I've ever used them, and even for somebody who's worked in the NHS a long time, it is tricky navigating your way through the service when you're on the other side, and I think we often forget that. So we'll take all that away and maybe pick some of that up with the primary care team.
Thank you. Excellent. Okay, now we have the item with the escalated alerts from the committees. Welcome, Sheena. I'll come to you last, Sheena, so that you can think your way into this. We'll start with Roy and the Finance Committee, please.
Okay, thank you, Chairman. Firstly, it's important to say that we have on the agenda today, I think, the first integrated performance report, a very comprehensive report, and I think that's really welcomed by the board, something we've been asking for, but again, as I say, it's a comprehensive report and it's much appreciated that that's been brought forward. We also have an up-to-date finance report as well, so some of the issues that I might reference in my AAA report are superseded by, I think, some of the financial issues that are being discussed within that report. However, I'll go back to the actual AAA reports firstly from the 27th of November. The alert there we brought forward was about the ICB strategy, and I recognise there is an infrastructure strategy here again on the agenda for this morning's meeting, but we did feel it was important to highlight an urgent need for an overarching strategy that incorporates the affordability, the clinical strategy and commissioning intention. Again, we have discussion on the clinical strategy and commissioning intentions, I think, later on in the report. So that's been picked up and is being taken forward by colleagues around the table, and we'll be hearing about that later. On the advisory part of that AAA report, we talked about the primary care clinical measures, and we've just heard a very interesting, I think, patient story about primary care, but we wanted to understand local variations within primary care. We asked for a request and an analysis on the primary care clinical measures by place, sub-ICB and the PCN and practice level, which I know is a huge amount of work, to be quite frank with you. We recognise that. However, I think it's really important that we understand that there is variations across our patch in terms of those particular clinical measures. I think we need to understand, I think, that how that changes, how that's being affected in different places and at those PCN and practice levels. And I say we've just heard about some practices as well. Financial challenges is the next part of that advisory report. I'm not going to go into that, but we did discuss that at length, and we wanted to point to the importance of developing a recurrent cost and reduction saving strategy and plan to bridge the gaps. The financial risk score, I think, is something that we really is perhaps one of the important advisory comments on within this particular AAA report for November. And we agreed to amend the risk score to meet the financial targets and deliver the improved productivity from 20 to 25. Now, Chairman, I think in the past we've discussed this at the board where we've raised a risk score to the highest level it can be at 25. But that's, I think, recognising that our current forecast suggests that our current forecast for 23-24 will not likely to be achieved. So whilst, you know, we thought it's important that we felt that the score should be raised, and it wasn't taken lightly, and it did have a robust discussion at the committee. I think it was really important that we said, and we made the board aware that the position, I think, at that time was really difficult, and we had to raise it to that level. However, I'll come back to that if people want to do. Under the terms of reference item, we agreed to co-opt the Chief Nursing Officer, or Sarah, to attend our future committee meetings, and that was obviously bringing a perspective of the clinical and quality aspect to the Finance and Performance Committee. On the Assure part of that particular report, we noted the progress on analysing the block elements of the acute contracts. Really important issue, I think, and consideration was now being given to the extent that the 24-25 contracts can be amended with regards to that particular block issue. I'll move on to the AAA report from the 18th of December. On the alerts for that, we had the East Lancashire Hospital Trust's EPR system, electronic patient record system, and I recognise now that that's moved on and that information is now starting to become available and is in a better position. We also recognise we should alert the board to the balanced financial position across the ICB in 24-25 being extremely challenging, but we also recognise that those will be discussed in commissioning plans that are going to be drawn up in the forthcoming few months. On the advisory points within that particular report, under the system recovery and transformation, we understood that a models of care clinical advisory group under the leadership of Dr. David Levy has been established, and its main aim is to articulate the vision and roadmap for clinical configuration. So that's part of something that we actually raised in the previous report, as you'll probably be aware, that I commented on. Also on commissioning, a major review of that particular service is being combined with contracting and commissioning meetings. They'll be introduced from next April. I think that's really important for us as an ICB. We've discussed commissioning previously on the F&P committee, and thought there should be a more important position taken on that, and that's clearly going to be taken from next April. On the Assure position, I talked earlier there about the discussions that we'd had in the November meeting. However, in the December meeting, we felt that it was important for us to tell the board and to assure the board that this year's current financial target is encouraging to note that our November performance actually suggested that the situation was stabilising. So I think it's fair to say that, you know, after 1 month, we might have criticised the financial position in the November meeting, and we knew we were in a difficult state with that. But in November meeting, we did also recognise that was particularly stabilising as well. So we have, Chairman, the approved minutes of the F&P committee held on the 30th of October for colleagues to ask questions on if they require to do so. But that was the two AAA reports. Oh, sorry, and the 27th of November as well. So I'll stop there, Chairman.
Thank you.
Ask if there are any comments.
Thank you, Roy. On the issues around financial performance in our organisation, in the system, we can pick up in Sam's report. Issues around the performance we can pick up in Asim's. But is there any other questions or additional points colleagues from Finance and Performance Committee wish to make? Okay, it's very good. I mean, it's an example, and we'll see it in the others. There's a huge depth and breadth of heavy lifting going on through the committees, and I think we're getting better now at the right issues that get referred into us to connect to our agendas and the business here. I appreciate all the work that goes on with executives and non-executives through the committee work, and we've got lots of evidence of that across the spectrum today. Can I just ask on this East Lancashire thing? Obviously, a lot of the performance for the patch is an aggregation of trusts, and it's not unusual for an interruption in reliable reporting when a new electronic patient records put in. Are we through that stage now, Asim? We can rely on the numbers that are coming out.
Yeah, I think for elective recovery figures and waiting times, that data is now coming through, so we'll start seeing that within the performance report.
Okay, thank you. All right, let's move on. Debbie, do you want to talk to us about the public involvement engagement and then the primary care commissioning, please?
Thanks, Chair. So you have the minutes from the PIAC meeting of 12th of December. Just a couple of items just to draw to attention, and happy to take any questions. There's no items for alert. Under advice, I just wanted to mention that we'd received a really helpful deep dive into the priority wards approach that's been developed and led by Andrew Bennett and his population health team, working really closely with place-based colleagues into local areas, and really gathering a real rich vein of engagement and involvement practice and also insight that's really important, both in terms of developing place approaches but also for the ICB. So we heard about the challenge around implementing that and maintaining the richness and it flowing across the whole of the system to actually add the benefit that potentially it can do, and that's something that we'll keep close to moving forward. The other aspects, just to quickly mention, continuing healthcare has been obviously an area of focus for the board and an area of priority for us moving forward, and we received a really helpful report and had an opportunity to get more assurance around the public involvement and engagement approach that's underpinning the redevelopment of the service and the new delivery model that's being implemented. And what we agreed to do is look back in 6 months' time as that work's continued to hear the feedback on that service to again sort of test and be able to offer assurance to the board. And then the final one, just to quickly reference, is around dental access and oral health improvement programme. So after the conversation and the review of the board at the last meeting around provision and the challenges there, we reviewed the engagement and involvement plan that underpins the communications around it. Obviously recognising there's some really hard messages there, because as we recognised in the board, there are gaps in provision and around access. So the communications around it and the signposting of people into other mechanisms and to ensure that supports there is obviously a key priority, needs to be done well to be able to pick that up whilst we look at areas of delivery as well. Okay. Primary Care Commissioning Committee, there's 2 meetings that are recapped, 9th of November and 14th of December. Happy to take any questions, but just to mention that we have started to look at in more detail the provider selection regime and what the implications are in terms of the committee's focus moving forward, and what we'll obviously increasingly need to do from January onwards, given its introduction, is consider how that might be implemented and impacted and used within our decision making within the committee moving forward.
Thank you. It's very clear. Any points anyone wishes to add or raise? Thank you. Good. Well done, Debbie. Jim, audit.
Thank you. Nothing much I really want to mention out of the notes, but the tone was different. So we're starting to see more positive assurances coming forward to the audit committee through internal audit reports and other pieces of work that are going on. So compared to where we were 12 months previous to this, where we had very little to kind of say things are going well, we've got a lot more solid evidence now to suggest things are going much more smoothly in terms of systems, processes, governance and the like. So it was a much more positive meeting than we've had previously. I'll briefly mention freedom to speak up because it's on our agenda today. The audit committee's role is around assessing the effectiveness of the arrangements, and that's still to be undertaken. So we're looking for Mercy Internal Audit Agency to do some work on that, and then we'll come back with our feedback on that in due course. Looking forward, just to mention that the next meeting, which is in a couple of weeks' time, we're starting to look at the Head of Internal Audit's draft opinion and the initial assessment of the annual governance statement. So it's kind of preemptive work for the end of the year, really, and we're hoping that'll be relatively positive. Kevin's going to come to a meeting shortly. We don't think this is the best one for him to come to, so we want to do a bit of preparatory work and then for Kevin to come along and to have a conversation with us around that sort of thing. But overall, it's a more positive report we can feed back from the audit committee.
Excellent, thank you. We've been in this situation where we felt a very critical approach from internal audit. We welcome the feedback and the criticism, but it's important that we make this transition now to that you've just described. Any points anyone wishes to add? Okay, thank you. And Jane, People Board, please.
Thank you, Chair. So we have a AAA report from November 2023 and 3 items to alert the board to. The first one is that we reviewed a belonging plan, which is a plan about diversity and inclusion. But we noted that at the moment it's just a plan for the NHS, and our aspiration is to make this a system-wide initiative. We really felt quite strongly that it ought to be something that a whole system could sign up to in terms of the key principles. So some further work is needed there, but we wanted to mention the current status of that plan to the board. The second alert was around nursing workforce for learning disabilities nursing. Or at least what we can do to mitigate that. The third one was around freedom to speak up. So we've got a paper on that today, and there are wider actions about freedom to speak up. But particularly we were concerned that from March 2024, the ICB takes over responsibility for supporting freedom to speak up in primary care. And currently we don't have the resource, the guidance or the implementation plan for that. So we're quite concerned about how that's actually going to work. So we need to keep that under review. And just one item to assure the board on, we are acting on the recommendations of Audit Committee, not just in relation to freedom to speak up, but more widely. And we have a development session later this month looking at reviewing the purpose and function of the People Board to increase its effectiveness.
Thank you. Aaron?
Thanks, Chair. Jen, just an update. We've asked Aisha Chowdhury, the Director of Culture and Inclusion, to come to the Provider Collaborative Board on the belonging strategy just to make sure we get joint board agreement and support for the agenda from NHS providers' perspective. And just a note, Aisha's done some great work in Morecambe Bay. It's important that we highlight, I think, colleagues who've provided broader contributions. She's done a great job with us, Chair.
Excellent, thank you. Aaron. And David, please.
Jane, to raise your awareness to some work that's going on. So the University of Cumbria have been in touch with People First, the organisation I work for, about the challenges with recruiting learning disability nurses, and we're doing some collaborative work around including people with learning disabilities in a recruitment drive process. So it might be that we could link up with what's happening here in Lancashire as well. The idea being that people with learning disabilities talk about the benefit of learning disability nursing and how rewarding that can be in order to kind of promote the endeavour. So, we can certainly connect about that if that's useful.
Yeah.
Excellent, thank you, David. Okay, yeah, Sarah.
Thanks, Chair. It was just to build on what David said. We are aware of that work, David, and actually our learning disabilities nurses, because we've got a few in the ICB, are also doing some work with University of Cumbria. So it's great, really, we can connect the two pieces of work. And I suppose this isn't a local problem, this is a national problem. So recruitment into nursing, pre-registration nursing programmes are down across all specialties, but learning disabilities is down more than any. And actually last year Cumbria actually closed and didn't run the programme. They are hoping to run the programme again this year, which is why we're doing a campaign. So it is a really, really important area for us to do some joint working like that and to try and attract people into learning disabilities nursing.
Excellent, thank you. I look forward to receiving progress report on all of that. It's great. And Quality Committee, Sheena.
Yeah, thank you very much. So what I'd like to do is to take you to the reports of our two meetings, which was the 15th of November and also the 20th of December. And I'll just focus on the alert items. What I'd like to just take you through is, first of all, those of the 15th of November. And the first of those is around waits in our accident and emergency departments. And clearly this is a situation where none of us really want to see people waiting long times, but unfortunately it is a feature of the challenges of demand over how to actually change the way that we meet need. And obviously that's really part of the transformation work, which clearly we will talk about later on this morning. So what I really just wanted just to say that clearly we're noting the risk of harm, but also thinking about how do we move forward with the prevention work in terms of looking at the whole pathway, but also what are the other mitigations around looking at reliable bundles of care for people who have to wait longer than we would want them to, and also the high impact changes. And the importance of looking at the role of the improvement in insurance groups and the work that they do, particularly in places, and looking at the whole system response to this. So that was our first of our alerts. The second of those were the work that's ongoing in terms of looking at children who are placed in inappropriate settings. So these are children who have very complex needs, who, because they, are trying to find the right place for the care for that, sometimes get placed for various reasons in an inappropriate setting in relation to being the optimal place to meet their needs in the best way. However, I'd just like to say that some very positive transformational work is going on to actually look at a different way of actually meeting those children's needs and to mitigate the risks that are there. So I think that's an alert, but something that I think is really good progress is being made by the system to respond to those young people's needs in a very different way. I'd like to then finally finish, and clearly there's been a focus this morning already about primary care, but this is around actually, unfortunately, an increasing number of incidents within primary care, which is requiring quite an intensive input from ICB staff to make sure that those are effectively understood and then mitigated in terms of and learning taken forward. So just to really ensure that consideration is being given to how we have the right resources to respond to those effectively and to then obviously learn and take things forward positively. So then the second set of alerts I just wanted to take you to was the meeting of the 20th of December. And the first of those is around health inequalities. What we considered was the work of the Learning Disabilities Mortality Review, and that, for members who aren't aware, is work that's undertaken to understand, to look at why, very sadly, people with learning disabilities have passed away, and the learning from that about how can the kind of system respond even better to the needs of people with learning disabilities. But what that does show that unfortunately there still is high amount of inequalities, and clearly that's something that we would all want to focus and think in a system way about how we can respond more effectively to the needs of people with learning disabilities and their families. We did actually look at some really positive mitigations that have been taking place, and I think that's something to note and to move forward positively on. And then I just wanted to just mention around a couple of things from our quality and safety reports consideration, and that was around just making sure that we look at the correct resourcing for palliative care, but also in terms of the need to look at a system again around our Regulation 28 note that had come in. This is about an incident that had happened in Greater Manchester, but there was some learning there across the wider system about what things could be done differently in the future. So I think that's all I just wanted to cover. Thank you, and happy to take any questions.
Points, questions? David?
We'll obviously come to the Freedom to Speak Up report later on in the agenda. However, I think it's important just to share with the board, we have seen an increasing number of issues, quite complex issues in primary care. Now, of course, we're a relatively new organisation. Are we simply seeing the number of issues that were previously seen by NH England, but now they're actually just coming to us instead? And so I did ask the team that in fact transferred across from NHS England that question. Is this business as usual, or is this new? And in fact it's new. We're seeing an increasing number of complex issues that are coming up which arise in primary care, which typically are now triggered through Freedom to Speak Up. And it does consume a vast amount of time, because in fact it's not just the primary care commissioning team that get involved and the medicines management team that get involved and the quality team that gets involved, but we have to work and liaise with the regional professional standards teams as well. So they are actually unfortunately quite complicated, and often the concerns of such concern that we have to respond in a very timely fashion. So it's really just to flag that up to the board. We're working on it, but nevertheless it does consume a significant amount of those teams' resource.
Thanks, David. Then I've got Angie, then David, then Vicky.
Can I perhaps defer to Vicky, because she's closer to this than me and probably will give you a better insight, if that's okay.
Yeah, and Vicky.
Thanks, Chair. It's really it's a comment and some thoughts around children in inappropriate settings with complex needs. And a little bit like the discussion we've had around GPs, it's not a new issue. You know, it's something that's been around for a long time. And they're not large numbers of children, but when we have those problems, they're really stressful and challenging for everybody. Is there an easy solution? No, but I think the key, and I think I've seen in the papers, there are some innovations and ideas that are happening around this area. And I think from Lancashire, actually, I think I've seen in the papers, from the papers. So I think the keys really are thinking about how we keep those relationships going, how we work together. But it's an area that I know we're not just struggling with it, it's happening all over the country. And I think the more we can look at bespoke solutions, ideas, that's often the key. There isn't necessarily a one-size-fits-all. So I think if there's anything we can do in this to bring back any ideas, thoughts, innovations, you know, it's something we should definitely think about. So there isn't an easy solution to it. There's absolutely not. We're all struggling with placements. But, you know, bespoke solutions is often the way forward. So I think anything we've got out there, anything we can research, has got to be a positive thing.
Well, it's very helpful, Vicky. But in quantum terms, how many children are in this situation at any one time across our patch?
It varies, but just to give you an example, before Christmas we had 4 children they were all Lancashire children at that point in terms of Lancashire County Council, but it does happen for the other authorities. 4 children who were in our acute beds for a long, long period of time that we struggled to place. We did, I'm glad to say, manage to place all of them before Christmas, but it was very, very stressful and very, very difficult to do that. And then there's the financial cost, which is key, but it's the cost and the harm to the individual children, because the impact of being in the wrong place for a long period of time, the evidence is there about the detrimental impact that has on these young children, and the time that took up of teams on both sides was enormous. So it is a very, very difficult issue, and I think it's an area where there's a real opportunity for some better integrated working across the teams. We do okay, but I think we can do more. And the initiative that was described at Quality Committee is it's an initiative with Lancashire County Council, because we've won a bid, haven't we? There's some funding coming in from the DFE to open up, but it's only 3 beds. It won't solve the problem, and it's going to take another couple of years. It won't solve the problem. So Vicky's absolutely right. We need to do some more innovative work. And what I wondered was, because there's also the children in care strategy that went through Quality Committee. So again, the number of children in care is growing across the patch. That as well, in terms of outcomes, these are our future. These are the adults of Lancs and South Cumbria. There's lots of issues there, and I didn't know whether at a future board you wanted to have a bit of a focus on children and young people, because it doesn't often, it's a bit like autism and LD, we don't often focus on it, and I think it might be helpful for boards to have a bit of a focused agenda where we look at some of these issues and the work we are doing and what more work we need to do.
Yeah. Okay, thank you. And David?
So you often hear me talk about this, but it seems like we constantly fail into improve or to move the dial on the outcomes for people with learning disabilities, despite everything that we hear about here and despite everything that goes on nationally. The mortality rates remain stubbornly, well, just absolutely dreadful, and we should be outraged by it, really, because we're talking about some of our most vulnerable citizens in every possible way. And even just thinking today about the access to services, access to GP surgeries for people with learning disabilities is incredibly challenging. It's challenging for the rest of us. So I'm keen that we understand or seek more assurance around how we're going to keep moving that dial for people, because despite all of the mortality work, we're just not doing it, and we're certainly not doing it locally and nationally. So again, I would wonder whether or not a focused agenda item on learning disabilities and autism would be useful at the board at some point.
Yep. Okay, thank you again. And so Sarah and Gina think about how we do that. Jim?
There's a comment about palliative care in Sheena's feedback, which I think is really important, and it's almost a similar point. It feels like we should have a discussion about that at some point in the board, because it is almost a Cinderella service within the wider healthcare system, and it just feels like the point's made. I think it's not currently ring-fence funding. Current resources are suboptimal. There's a piece of work for us to look at there, I think.
Yeah, okay. I don't know what you think, Kevin. I winced slightly. I took it in the spirit in which it's intended, but I winced slightly in this AAA report at the judgment from the committee about funding being suboptimal in this area. I mean, we might conclude that, I'm not saying it isn't, but we might, on every item that we discuss, we could say, well, funding's suboptimal. We can always do more with more. And there's just an issue about how we get the right awareness raising and insight and depth from a discussion in a committee which involves people from outside the system, without it being a pressure groups type statement, which is, on this single issue we need to do more, because there's lots of other issues. But I guess that the route is that sort of intelligence and insight feeds through you, Sarah, into the executive and broader discussions about choices and resources. Okay, anything you want to add, Kevin?
I think there is a transformation opportunity in that space that we shouldn't lose sight of. We've still got a lot of planned deaths, for example, in hospital. So the team are looking at that. We're trying to get some focused resource around it, and I think it doesn't carry some of the big numbers, but it is actually a significant area that we shouldn't lose sight of. So yeah, budgets are probably suboptimal in every area, but I think there is a transformation opportunity here that could produce some big benefits for patients and better use of resources going forward.
Great. Look forward to all of that. Thank you, Sheena. Let's move on. The infrastructure strategy 2023 to 2040. Let's all imagine where we will be as individuals in 2040 and hold on to that context when you think about this infrastructure strategy.
Thank you, Chair. Okay, so what we've got in our board papers is an overview of the infrastructure strategy with a link to the website with the full strategy on it. So the board had some dedicated development time on the 6th of December, which also fed into updating this strategy. So it's now ready to go onto the website. It is a requirement of NHSE and it builds on previous strategies. This isn't something new we've just come up. This has been building on a number of engagement events, communication and work on developed strategies for Lancashire and South Cumbria over a number of years. So it's got a fairly long timescale, as the chairman's pointed out, but due to the nature of it, it needs to, because it looks at that longer term work that we need to proceed. We're getting more into the transformation space, and because it underpins our strategy is going to be delivered over a number of years. So it will support the direction that we do have strategically around prevention, around our out of hospital offer, about right sizing our acute trusts, and incorporates the new hospital programme. So those sorts of timescales, then when you add in the green targets that we have by 2040 and 2045, they are quite long-term timescales that we need to look at. The document should therefore tie into all other strategic documents that we see and the board has previously seen, approved or noted. And I think when you read through the infrastructure strategy, I do think it does quite a good job of setting out some of that strategic direction and the things, hopefully everybody will recognise it's the direction of travel that we've all been talking about. Just some stats that have come out in the strategy that I think are really important is, you know, almost a quarter of our health buildings predate the NHS. So quite old buildings across our patch. We have 400 different health buildings and we have about £300 million worth of running costs to support them, which is pretty high, and it's 1 million square metres. Our backlog maintenance is around 180 million, and about 100 million of that is quite high risk backlog maintenance. We're only funded around, or only allowed funding levels of around 100 million a year to support our capital programme. So most, as you can see, most of that goes on backlog maintenance. But what this strategy does is it looks at what is required over that period, and it's a long time scale, but it sets out a sort of 5 billion ask. Now that doesn't incorporate all the net zero requirements that we may need, which may need some investment because we haven't done all of the work on that yet. It's still progressing, but a 5 billion envelope is set out in there. It aims to review the estates in light of future needs, and it plans to review those parts of our state that we want to keep and maintain. So it breaks it into 3 parts when we go through the strategy. It says, what are those areas that we want to maintain and keep because they're really good, they're doing the job, we need them to continue. And we refer to that as core. This is a national terminology that's been brought in around infrastructure, so we call it as core. And there's those areas where we might want to keep, but we'd have to develop them, which is called flex. And then there's ones that we no longer require and we need a disposal process around that, and they're called the tail. So that's how you'll see the terminology. What the strategy does have is a clear glossary in there and some real definitions of what's meant by that. But it builds on some really important principles, and I think this is what's key in the strategy really, that it includes value for money, as you'd expect. When we're spending 300 million of running costs, we would expect to try and use that as efficiently as possible to run the estate. But it also looks at how it supports our strategy and use space effectively. It also supports healthier places and supports the transformation agenda. And the next stage of this will be developing this into more detailed plans, which will be done very much in partnership with all of our partners across and our public across the patch, across the Lancashire South Cumbria, and pushes the use of digital as well as part of the principles in terms of how we are going to communicate with patients and how we're going to use technology to really input into the design of our build. And that's really important that we link the digital strategy into the infrastructure strategy when we do that. We have the green agenda, as I've mentioned, but the other thing that you'll see in there is this term usership, and I think that's really, really important, because when we get into the work of working with our partners, this isn't about us all owning every building. This is about how we use our building effectively and support partnership working. And we had a little bit of quite a good meeting yesterday with Lancashire County Council where we talked a little bit about this, but there are some really good opportunities for us to think about how do we use our buildings and our estate more effectively, as opposed to thinking we've all got to own everything. So I think that's an important part of the strategy. There are some key dates in there, as I mentioned, the green dates and the new hospital programme, but also PFI and lift dates, ending dates in there as well. And in terms of the ask financially, although we don't have all of that identified, what we do know is even over this last couple of years, capital does come out. We get sort of asks to put plans together, and the recent examples will be community diagnostic centres, digital and pathology are recent examples. And so what this is trying to do is set out the ask and then get everything ready. So we need to be building up the business cases, getting ready for any other capital that comes out, and setting out our plans, addressing the backlog maintenance and driving the new hospital programme. So that in essence is what it's aiming to do. I know we've had some time in more detail as part of a development session, but I'm happy to take any questions.
Thank you. It's not ideal when we just provide a link to a document elsewhere, but we, as a group, we looked in workshop session with Alistair and Sam through a lot of the detail, and this report summarises well what the strategy sets out and the points that came in that discussion. But we can take more points or questions now. Jeff.
Yeah, and thanks, Sam. Thanks, Chair. I know this is going to take a long time to realise our ambitions, but I just wonder what are the things we can do now that don't cost us much money. And you know, and people have better ideas about estate than me, but just 2 or 3 things from my experience. You know, one on the green agenda, are we maximising the encouragement to all our staff to be green? You know, in travelling to work, electric cars, or travelling together, or travelling on you know, that kind of thing. So that's one thing. Are we just doing that? That wouldn't cost us any money, would it? Really? Maybe a few charging points in the car park. I think there's a really strong cultural thing I've seen in primary care that's difficult, and which is people become very attached to their buildings that are no longer fit for purpose. And I mean, I found it devastating to leave the building. My corner shop I've been in for 25 years to move to a fantastic new health centre. It was really traumatic, because I'd lived and breathed every minute of that building. But actually, that's not a good emotion to have, is it? When actually we need to be aligning people to what's the strategy. So I think there's a bit of work to be done there, and that doesn't cost any money. But about you know, realising I work in places which are not safe from a health and safety point of view, or an infection prevention control. Windows don't open. Well, we all know we need to open windows because of COVID, etc., etc. And so that was the green agenda, the emotional attachment. And the third thing that really frustrates me is the reluctance of the professions to share space and use space more effectively. That doesn't cost money. So if you've got a building that's open 12 hours a day, why not use it 12 hours a day? And so I just think we need to have a short-term sort of push on the state while we're awaiting the long-term strategy.
Do you want to respond to this point, Sam, and then I'll bring Angie?
Yes, I will do. Thank you. And I think it's a really important point, and I think we are doing that. I mean, there's always there's always opportunities to do more, but I think it's not just us, obviously, it's all of our providers have got green plans. They've got, so we've got examples of where people are archiving paper, you know, from a green perspective, but saving money on space. We've got those travel plans. In fact, we're sitting in a building now that we didn't have a while ago, that we are working in partnership with our council colleagues here, and it's actually saved quite a lot of money by coming out of a lot of other buildings, by looking at space utilisation. We have a clear space utilisation plan, and we're working with property services to look at how we could do that more across primary care as well. So I think there is a lot going on, but there's never enough, is there? So I think it's a really good point, but the green agenda actually isn't just, you know, there are actually financial benefits that drive that, as well as obviously all of our climate benefits, so it's important. Thank you.
Thank you. And Angie?
Thank you. So I did click on the link to the 90-page strategy, and it is a very comprehensive strategy. I think our task now is to recognise this as an effective lever to achieve some of the things that we're deeply committed to, particularly in terms of that shift left to the community-based provision, and actually addressing some of the issues which we've talked today about children with complex needs, and actually having local facilities that can meet those bespoke needs in the locations and to the quality that we require. So for me, I think this gives us a real opportunity, if we use this wisely, either to repurpose some of those assets to provide those facilities, or to generate a receipt, which means that we can provide different types of facilities. But the challenge, of course, will be not to try and replicate what we've already got in modern facilities, but to bring that innovation that we have consistently talked about to redesign those spaces. So the next stage around, from our perspective, Focus 9, about the community work in the locality is going to be really key, and it's going to have to be a true partnership ambition, including not just local authorities and the NHS, but our VCSF and providers is going to be really essential. So we're really up for this, and as we said, we had a positive meeting yesterday at the County Council to see how we can drive that forward. Thank you.
I just wonder, in the context of the points that Angie's made, whether amongst everything else we have to do, we've got sufficient focus and priority, particularly on the tail properties. I felt this in the discussion before. You know, we use language of phasing out. Is there something more proactive that we can do in terms of those properties that we don't see a long-term future for, but are costing us quite a lot in the meantime?
So that's exactly the work we're doing. So we're trying to push that as quickly as possible. Some of those have already gone, and over the last year. So we're now working on a number of others, and this is where working with our partners in property services is actually helping as well. So we are doing that, and I think it's really important that Angie's point that she's just made is really important in terms of this is now ready to start using as that engagement document into what do we do next with our partners. And actually when you look at the transformation programs that we're starting to put together, estates is a key enabler throughout all of them. So I think this, and the voluntary sector are absolutely key to this as well. When we start looking at what our strategy is trying to achieve, how do we look at this across the whole of Lancashire, South Cumbria? So I think it is really important. So I think it's quite an exciting time now.
Thank you. And Roy?
Thanks, Chair. Very much welcome the joint working with the local authorities on this. We did some joint working with Blackpool Authority and from a CCG perspective, and we built there a new GP surgery. Two GPs went into a surgery, and part of that new build was access to social care within the same building, which I think is really important. If we're talking about an integrated system, I think that's what we should be aiming for. I think it's really important we try and do that. Can I just mention as well, just briefly, Chair, if you don't mind, I think we're all recognising that there's a huge amount of new builds taking place around Lancashire and South Cumbria. Seems to be in my area, and I'm sure it's happening in other areas as well, housing estates. And part of that is we can access money from these housing companies to build health facilities within those areas, and I think it's really important we don't forget that, because if we can get money through that way, and we have done in the past, I can't remember the section 186, is it? Section 106 agreement, yeah. Section 106 agreement. And I know that's been used, and our property people are well aware of it. But I think it's important that we also recognise that the pressures we talked about earlier on primary care are being exacerbated by these new builds and people moving into them with children and whatever, and going into the primary care facilities we've already got. Well, it's about time that we did get some money from these private providers and the private housing providers to support new health facilities within these areas, so that people firstly have access that is local, and they don't have to access existing facilities as well.
Thank you, Roy. We pick this up, Sam, as part of the taking the strategy forward, yeah?
Yes.
Thank you. We've got Kath, then Jim, and then I'll move us on.
So yeah, I think it's a really exciting conversation, and great to see that those conversations have started with Lancashire. We're having similar ones at the moment, and Kevin, we'd met just before just after New Year, wasn't it? With Sam Plum, the Chief Exec. So we'd be keen to have conversations as well with yourself, thinking about modern services that fit for purpose, fit for the future. And I think as well, we talk about children and appropriate places. Let's not also forget our adults, particularly with learning disabilities, who often are placed hundreds of miles away from home, and we know some of the impacts and outcomes of that. So really, really keen to keep people close to home as much as possible. So yeah, very much up for that.
Thanks, Kath. That's excellent. And Jim?
Thank you. Yeah, we discussed this in more detail back in December, as people have said. It's what we do next, really, and it's how it comes back into this meeting here. So it's almost putting flesh on the bones I'm interested in, really, and how often and when are we going to get updates on it? There's a whole range of different aspects associated with this infrastructure strategy, and it's really, really important. It's crucial to the future of what's going on in the ICB. But we need feedback on it, and we need to see a little bit more detail now, I think. So I absolutely agree with this in principle, but it now needs developing and coming back here on I would have thought, a reasonably regular basis.
Yeah, okay. You guys, Kevin and Sam, work on that. Thank you. So can we approve this, please? Thank you. It's good discussion. Particularly powerful point you make about net zero, Jeff, as you come in a different car to every meeting. Right. Resilience and surge planning, winter. Craig, please.
Yes, thank you, Chair. So this is a regular update we've been bringing since the autumn now, and the paper's here, and I'm happy to take any comments or questions, but just to orientate board members, it covers our emergency and urgent care and emergency recovery plan and assurance, the capacity investment funding, the implementation of the 10 high impact interventions, and winter preparedness. I wanted just to take a lead from Kevin with regards to just giving a flavour for winter and how we've managed that. And I do thank both Aaron and Kath for the comments on the planning, as we've spent a lot of time this year in our planning for winter, and I think that's paid good dividends. However, it has been an extremely busy period with a further 11 days of industrial action that we've just experienced over both Christmas and New Year. There has been real challenges with regards to elective care and some of the cancellations, and it's just in the context, we had an incident on Christmas Day of a fire, and we've also had flooding that we were recovering from as well. So this has been a very busy period for the NHS, and I do want to thank our providers, and I mean both the NHS, our primary care providers, the voluntary sector, but also our council partners in pulling together to help with not just patient flow and discharges, which sometimes can be often the focus, but also management in the community, deflection and support for helping people with regards to alternatives to our accident and emergency. As you'd expect, during winter, some of our performance has slightly dipped. We've had really good responses still, though, with our category 2 mean times for our ambulance turnaround. So although the Northwest is just over 32 minutes, actually Lancashire South Cumbria has been under that often and brings the aggregate position up, so that's a positive position. We have seen some 60-minute delays in our hospitals post-Boxing Day. Again, some of that was expected, but we've not seen the 8-hour plus delays on the ramp, which you've heard nationally, and I think that's a really good position to be in. Our 12-hour waits in A&E have reduced from last year, but I don't want to be complacent because obviously people waiting in A&E for 12 hours is still absolutely not acceptable. But we have seen a reduction, and we are just under the 76% national target for 4-hour response in A&E. That is better than other places. However, again, that's no reason that we shouldn't be aiming for higher, and we want to obviously achieve our targets by the end of the year. So there is further work to be done now over January, February and March to recover that position. We are actually in a better performance position to this time last year on most of our figures. But just to give you a real example, despite being slightly better, Blackpool alone saw a 16% increases in December purely for ambulance attendances. So that was 391 more ambulances in Blackpool than last year. So that is just an example of one of our providers, and I'm sure if we then looked at all of them, that gives a real, I think, illustration of the demand that we're seeing. The hotspots, as Aaron pointed out, were Blackpool and East Lancs. Blackpool has opened its emergency village as well, which has been positive, but obviously the new model of care is taking some time to bed in. Just some slight other elements that relate to our winter and surge planning. We've reviewed our virtual ward capacity. Our virtual wards have seen a better improvement in access, but it's still not near the percentage that we want to be. But this week we were at 69% compared to low 40s in previous months. However, that's slightly masked by the fact some of our providers are near 100% and some are much lower. So, but we are going to be reviewing that with regarding our investments for next year. No right to reside for medical criteria patients is mixed across the patch. We still have some challenges with some of our local authority areas, but I'm pleased to say we've been doing some really positive work. We've got the LGA in parts of South Cumbria supporting a review, and we've been working with Lancs County Council to help some of the push through, but it is still a challenging position. We are still in tier 3, which is the lowest tiers for assessments, but that will be reviewed in quarter 4. We are hoping to remain in tier 3, and we've done a workshop this week with all of our providers regarding resetting our winter allocations. So we're doing this very early for next year's winter preparation. So I'm happy to take any comments or questions, Chair.
Thank you. Good report, Jim.
This is an observation, really. Well done. Basically, just simply well done. It's much more positive than I expected at this time, particularly given the strikes that have gone on. So to have coped, for the system to have coped, and it is the system, the whole wider system to have coped as well as you've just described is I think great news actually. So I'm not going to say any more. Just well done.
Sarah?
Yeah, thanks, Craig. And I echo what Jim said about how the system's coped. I suppose I was just looking at the table around the 10 high impact actions, because the alert that came through Quality Committee, when we had the focus at Quality Committee on safety in urgent and emergency care and the concerns around safety, and I didn't come back when we talked about that, but we are getting an increasing number of Reg 28s from coroners around harm that's happening on urgent and emergency care pathways across the patch. The discussion led to that, again, if I speak to regional colleagues from a safety point of view, they'll often talk about the 10 high impact actions as being your first go-to as a system. It's really, really important that they're in place. That's what, that you need to do that, and that's part of keeping the flow going and should help with harm. So looking at the table, I wasn't fully sure the descriptors, early maturity, progressive maturity, mature, what that actually meant and whether that meant those things are fully in place or not. But there's a couple of key ones there where we're not mature, which I think is like single point of access, the transfer of care hubs and intermediate care, that possibly would make a massive difference, really shift some of our challenges for our acutes in terms of flow and moving people through the system. So I suppose it was just understanding how, going towards next winter, we're really going to move the dial on those. Thanks.
Hold on to this point, Craig, and collect from Angie then, Roy.
Thank you, because I wanted to build on some of Sarah's points. So firstly, I did want to say, to acknowledge, it's really great that we have a relatively high performance across our system and that partnership working. And I think over years we've demonstrated really strong partnership working in Lancashire and South Cumbria, which is good for our residents, albeit we continue to experience significant challenges. I also, not being steeped in NHS language and stuff, there are a couple of points of clarity as a board member that I would have welcomed, similar to but probably a little bit more processy than Sarah's points. So in terms of Appendix A, I wasn't always sure whether the metrics which were being talked about were positive or negative. It might be clear to others, but it wasn't clear to me. So I'd like that clarity. And accountability and assurance that is coming up to this board, I wasn't sure where that was coming from, because recommendations refer to 3 separate boards giving us those assurances, so that I wasn't quite clear how that governance arrangement was working, and it's probably fine, I just need to understand it. And then just finally, you would expect me to say this, but just to remind the board of the importance of good quality social care in the community, which is really important to avoiding admissions in the first place and reducing readmissions. And of course, as we have social care at that interface, which is really important with the hospital, there's a trade-off with what's being done in the community. So again, as we pivot to more community-led work, we're going to have to sort of work through the implications of that. Thank you.
Thank you, Chairman. First of all, thanks very much. Agree with Jim on the reports. Really, really good report. Excellent report. But when I was reading it, I was just talking about the capacity investment funding, the urgent emergency care investment funding, and I was just recalling, I think, perhaps a couple of years ago now, we got some winter access funding that came through to CCGs, and some of that was directed to extended access appointments in primary care, which obviously would have an impact on UNE attendance. I was just wondering, I couldn't see anything in there about extended access appointments, but it's basically appointments that are out of the usual hours of a GP surgery, and usually in walk-in centres, I think, or places like that. Those are, yeah, still doing those. Okay, right, that's fine. Thank you. Thanks, Chair.
And Aaron?
Thanks, Chair. Yeah, I think the system, as I gave in my update earlier, has performed well this point through the winter. And whilst that's positive, particularly in comparison with other patches, there's still too much unwarranted variation between places and providers on particular areas where we focused improvement. So whilst we've got good focus, I think, on urgent care transformation under the Recovery Board, I'll pick up with the PCB quality leads through the IAG infrastructure about some of that lower level and quicker service improvement focus, because I do think there's still some spread of good practice that we could get better at sharing, which might release some pressure on investment for next winter if we can get it right over this next period. So we'll pick that up through the PCB infrastructure, Chair.
Craig, there's a number of points that Angie and others have raised. Do you want to come back on them, please?
So just in relation to Sarah's points, the maturity is an NHS England maturity assessment. So I absolutely agree with you, Sarah. That will form now a part of our improvement plan as a part of our urgent and emergency care transformation for next year. As you know, we've got a number of programmes that we're reviewing, intermediate care and care at home, and our transfer of care hubs. So when I bring a paper back to the board on the transformation element of urgent emergency care, you'll see how we're going to look to address those areas that are of lower maturity and how they're going to feature as a part of our improvement plan with specific interventions. So I think that's a good point to raise, and it will lead nicely into the paper that I bring in the future. On Angie's comments, again, the appendices, NHS England's reporting, some is positive and some is negative, so there is a difference, and I'm happy to take some of that offline. The reporting at the minute goes to our urgent emergency care boards, and unfortunately they've nationally decided to still map them against our hospitals, so they don't map to our places. So what we introduced was a system improvement board, so we could have a Lancashire and South Cumbria view, and as Aaron says, that reports to our system recovery board. So the governance absolutely is in place to link directly to here. We would have liked that to be on a place footprint, but unfortunately the hospitals are still the focus in relation to urgent and emergency care. And just with regards to the investment funding for next year, that's not been allocated yet, so we need to see what the allocation is and review all of our current interventions, the impacts that they're making, the benefit, and then ensure that we have a robust plan for next year. And we're doing that, as I said, early on, because we've just started the workshop. Thank you, Chair.
Thank you. It's very good. I'll reiterate the points that Jim made in the first response to the paper. These numbers are a reflection of the fantastic commitment and work that people are doing across the whole of the system, and will continue to. It's as tough as it's ever been in terms of the pressures on the system. I think that as we said before, in urgent emergency care and in elective work and cancer work and so on, comparisons with other places gives us context, but we should not draw comfort from it. I think we're better than being happy sitting above the relegation places, and it's so. But I'm encouraged that the spirit and the tone of the discussion on all of that today is a determination to continue to do the best that we can do. Well done, Craig. Performance report, Asim.
Thank you, Chair. The performance report in the pack is largely based on validated data up to end of October, but some of the areas such as urgent and emergency care benefit from more timely data. In this month's report, we also published performance data against the metrics recently published as part of our second half-year submission. And this is referred by NHS England as the key headline metrics, and probably will focus on that today. And as already covered by Craig, our front line is always under considerable pressure in this winter period, and this year has been no exception, especially with the additional complexity of industrial action. So firstly, I would like to offer my sort of commitment and thanks to our frontline staff who have worked tirelessly over this period, because sometimes these kind of reports don't really acknowledge that fully. So I will take the report as read, but I will focus on the key headline metrics I've just mentioned. I will not go into too much detail around urgent and emergency care because Craig has comprehensively covered that. But suffice to say, in summary, our A&E for our performance remains in the top quartile across England. Is a 7th place out of 42 ICBs across England. In terms of our core general and acute beds available in November 2023, they were slightly above plan. Bed occupancy post-COVID met a sort of record high in mid-October, but since mid-November occupancy has been falling, and this might be a reason why some of our 12-hour waits and ambulance delays have been easing. Moving on to elective recovery. In the elective recovery domain, our waiting list across Lancashire and South Cumbria continues to grow, and in October we had 247,000 patients waiting for treatments across the integrated care board footprint. To remind the board, the number of patients waiting before the pandemic was approximately 120,000, so it's nearly double the number of patients waiting. And of these, 100,000 were waiting up to 18 weeks, with very few patients waiting over 52 weeks, just for context. And nationally, 7.73 million people are waiting for treatment, but there has been a decrease in people waiting nationally, although a slight decrease of 0.51%. And we've seen also this decrease across North West as well. However, Lancashire and South Cumbria is not following this trend. We saw an increase in our waiting list by 3,016 patients in the month of October, which was an increase of 1.24%. So we are looking at this in more granular detail. We can see for areas like Morecambe Bay and Blackpool, there has been decrease in the waiting list, but we can see increases in East Lancashire and Central Lancashire. The largest increase has been in West Lancashire, with an increase of 1,280 patients, with the highest increase in gynecology and ear, nose and throat services. We are looking at this because these are services are provided, some of these are provided out of our patch. In terms of long waiters, Lancashire and South Cumbria proportion of total number of 65-week waiters have been falling until July 2023. And what we then saw after July, probably because of the impact of industrial action, they did start increasing slightly. But if we look at a longer term baseline position from April 2021, 65 plus week waiters, we proportionally have greater reduction across Lancashire and South Cumbria compared to North West and national positions. And also the percentage of our overall size of our waiters over 65 weeks compares favourably with the North West and the national position. And also to remind the board, all of our providers have reaffirmed their commitment to deliver 078 plus week waiters by the end of March 2024. In terms of actions being taken to reduce our waiting list, I think our performance is really positive in this area. So if we look at day case, procedure rates and capped theatre utilisation, we compare favourably again across the national and peer system performance. And latest performance for cap utilisation, theatre cap utilisation ranks the ICB as a second best performer across the country. And again, that's more for context. The final area covered as part of the key headline metrics is cancer. And to remind the board, on the 17th of August 2023, NHS England announced a change to cancer waiting time standards, which came to effect on the 1st of October 2023. These changes include the removal of the 2-week target in favour of reducing the current total number of waiting time standards from 10 to 3, so the reduction of standards from 10 to 3. And just to remind the board, these 3 standards are the 28-day faster diagnosis standard, the second one is the 62-day referral to treatment standard, and then the 31 decision to treat standard. And when we compare our performance across Lancashire and South Cumbria, there is a lot of variability, both across provider organisations and also across the different standards. But in relation to the key headline metrics, if we look at faster diagnosis standards, which is part of the key headline metrics, we do perform higher than the national average, with both University Hospital Morecambe Bay and Blackpool Teaching Hospital meeting the faster diagnosis standard. And we also are ahead of our cancer backlog plan. But if we look at some of our other metrics, none of our trusts are meeting the 31-day target, and none of our trusts are meeting the 62-day target. And in relation to the 62-day target, we are behind both national and regional positions. There's a lot of work taking place in this area. There is a wide-ranging cancer improvement plan, which looks at reducing diagnostic delays and increasing surgical capacity. And there's a lot more detail behind this information. So these were the key headline metrics, but before concluding, I just wanted to pick out something that is not part of the key headline metric, but is really important around mental health and out-of-area placements. So as I mentioned at the last board meeting, this is a long-term commitment for us to improve accessibility and quality of our mental health services, and this includes the elimination of inappropriate out-of-area placements. This is important as inappropriate out-of-area placements has long-term implications for individual recovery and outcomes. So out-of-area bed days remain significantly over plan, despite a further significant fall on the previous month. So we are heading in the right direction and right trajectory. And following recent investment, 12 beds were opened in the Greendale Adult Acute Ward on the 5th of December, very recently, all of which are occupied. So that points towards the pressures that we are facing. And in addition, 8 beds were opened in the Buckley Adult Psychiatric Intensive Care Unit, out of which 6 are currently occupied. So I'll leave it there in terms of the key headlines I just wanted to mention. But before finishing, I just wanted to make the board aware of a recent NHS England statement that was published on 27th of November. And this was in relation to health inequalities, duties under Section 13 SA of the National Health Service Act 2006. And the overall purpose of this statement is around encouraging better data quality, completeness, increasing transparency, and provides a tool to monitor improvement around reducing inequalities. And NHS England have provided a number of metrics that we will need to now analyse our data and provide different lenses on how we present our data. For example, elective recovery, we will be presenting information that will look at the size and shape of our waiting list. This will include deprivation, ethnicity, gender and sex. And there's a number of metrics that we are as a duty will need to look at this from a trust level and ICB lens level. So we'll pick this up as our continuous development of our performance management framework, as described in the recent board development session that took place last month. So I will pause there, happy to answer any questions with support from my executive colleagues. Thank you.
Thanks, Asim. A good paper, well presented, thank you. Any questions, comments? Got Jeff then, Sarah, I've spotted them, I'll come to you.
Yeah, I mean, we've moved on the primary care bit into describing hypertension, and that's great. But I think what we could do would be to say, we're looking at that because we want to reduce the number of deaths of strokes, heart attacks, dementia. What are all the drivers of that? Smoking, cholesterol, diabetes control, and blood pressure, and atrial fibrillation. So actually, it would be great if we're going to have a snapshot on one thing to have all the data on all those bits together. And because what you'll find is, and this goes for me and everyone, a clinician, we have a range of targets to do, and we probably fall down on one or two. It goes very much to that conversation about palliative care earlier. There's a range of activities you do for a particular clinical thing, and you really hit the target. So GPs really hit the target on do not resuscitate orders, but they don't get it quite so good on other bits in palliative care. The same with diabetes care and the like. So it'd be just to see, I know maybe I'm asking too much for this report, but just to see a bit more detail around one subject, and maybe we could move from subject to subject over. Maybe that's your plan over the months, but if you're looking at stroke care, can we have a look at all the things that drive it?
Yeah, no, that's a very good point, Jeff, thank you. It'd be helpful. Got Sarah next, please.
Yeah, thanks, Chair. Thanks, Asim, really good report. And I'm glad you brought the last point, because I was going to say one of the concerns is the cancer, because a bit like David's point earlier, we're not shifting the dial on the LD, we're not really shifting the dial on that. And my concern is within those figures, there'll be significant health inequalities variation. So I would really welcome that more detailed reporting so we can see the groups who are probably waiting even longer than the headline figures. My other comment was linked to the LD and two things, and again really, and I know it often improves at the end of the year, but just to build on David's point earlier around learning disability mortality, we're still quite low when it comes to health checks. And the other point that really was raised at Quality Committee, it's not just the number of health checks, it's the quality of them. And actually what we find is the quality is really variable and some of the quality is quite poor. And I think, if I remember correctly, Sheena will correct me if I'm wrong, some of the themes coming out of the learning disability mortality reviews does show where there's probably been some preventable deaths that the health check wasn't as robust as it could have been. So to David's point about what more can we do, this isn't just a thing, it's not just about improving our reporting so we perform better. It is about that real impact. And then my last point linked to that, the waiting list data. I feel quite strongly about this. It's obviously it's there, but really what we're reporting there is waiting lists for physical health weights, aren't we? And actually, if we were to report our weights for autism assessments and other assessments, they are even more eye-wateringly wrong than those headline figures. And I don't know whether at some point it would. I think it's really important the board is cited on that. It's not just a Lancashire Cumbria issue; it is a national issue. But I think, again, it's an area that's a real challenge, and we discussed this with colleagues from Lancs County Council yesterday because it's a challenge for all of us about how more we can collectively lobby. And actually, if we don't even see the data on what those weights are locally, we haven't got the evidence to lobby with. So it's something that I would welcome in the waiting list if we could have those broader categories.
Thank you. Also very good points. I've got Abdul next and then Sheena.
Thank you so much, Chair. Just on the issue regarding cancer, there is a cancer early diagnosis steering group, which I'm part of with our clinical colleagues and obviously the Cancer Network. We've been discussing several things really within that group, clearly around screening programs actually being one, which are a responsibility of NHS England colleagues. So that we do have a workshop on the Friday the 26th in relation to how we can improve our screening rates and address some of those health inequalities, just to assure the board in relation to that collaborative work. In terms of the early diagnosis work, obviously there's a range of measures, but there are potential funds that may be available in 24-25 in terms of working with our communities to ensure really that the key programmes around breast, cervical and bowel in particular, as well as AAA, are actually increased as part of the overall recovery programme. So there is quite, just to reassure the board, there is quite a bit of activity around this area to actually get the early diagnosis part of the pathway kind of slightly improved. Thank you.
Thank you, Abdul. Excellent work. Sheena.
Yeah, just like to commend for the improvement in terms of this report. I think it's really starting to shape up and really helping. I think as we move forward and we further understand how to inform what we're doing with the strategic objectives, but also the transformation work, it'd be good if we could kind of link even more the performance report to what are the transformation goals that we're trying to achieve, so that we can see, are we really turning the dial in some of these areas. But I just would like to thank you for all the work that you've done on this, Asim, because I think it really is starting to move forward positively. Thank you.
Yeah, absolutely. Thank you. We've got Angie next and then David.
Thank you. So again, I would like to say I thought this was a good report, and I thought the dashboard was really helpful. I'm always struck when I look at our dashboard, and I know this is a new one, that 2/3 of our indicators are red compared to a third being green. And I never know whether I'm relatively pleased or horrified that this is one of the better performing ICBs, because it is a reflection of the state of the nation's health. But I think we have a responsibility here as a board to link this to the outcomes for our residents. And what we do know about the residents of Lancashire and probably South Cumbria is that their outcomes are poor consistently, and they have been for generations. I do think it's inherent on us as a board to think about how periodically, maybe annually, we look at those wider outcomes. The responsibility for that currently sits with the health and wellbeing boards, and will segue into the place-based boards. But I think we just need to have a bit of a think about how we have that debate, the so what question. We could be performing fantastically, but if it's not affecting those outcomes, we need to be thinking about different ways of doing things, and perhaps different conversations with NHSE, because they effectively set a lot of this framework within which we're operating. So don't have the solution for now, but I think it's something we as a board need to take responsibility about linking this back to the outcomes on a periodic basis.
Thank you. Agree. It's good. David, then Debbie.
Thank you. Coming to the slight defence of cancer, I mean, the good news is we've got 3 measures which are very simple now. If you can deliver the 28 days faster diagnostic standard and the 31-day from decision to treat, you'll hit 62 days. That's what should happen. And what we can see is we are making significant progress with the diagnostic work, but there are challenges around that decision to treat. Now, in part, that is down to the fact we're actually tackling the backlog. We have had patients who've waited more than 31 days. Unfortunately, we've had some patients who've waited from a decision to treatment of more than 62 days. As you treat those people, as you reduce the backlog, they count negatively against the delivery of a 31-day standard. So, in some respects, as we see us reducing our backlog, and we're doing that quite successfully, you won't deliver 31 days. However, there are some exceptions, and undoubtedly Lancs Teaching Hospital remains as a Tier 1 trust. It has national support for its cancer challenges, and we are tackling issues around the urology and lower GI, that's the lower bowel pathways, and we are seeing improvements. And the final thing, to end on a positive note, we have been challenged by the number of dermatologists who work within Lancs and South Cumbria. So we have just worked on development of what's called an e-derma service. So basically this involves patients having a high quality picture taken of a skin lesion, gets emailed off to the service. Patient doesn't have to move, and they get sorted out and triaged, and only the people who need to be come and see the specialist. We're getting there.
Thanks, David. Well done. Debbie?
Thanks, Chair. It's cancer again. So my sort of reflection, and it's always the thing when you come in at the tail end of questions, isn't it? I think there's been a lot of interest and there's been an ongoing concern really around the performance in this area, and I wondered if it's appropriate and there's an appetite for maybe Finance and Performance Committee to get closer to this as an area of delivery to support board to have that assurance in key areas. I'm conscious that we're moving forward on one of the 3 core standards, but we're not on the other 2. It strikes me as quite a complex area where there's delivery by different partnerships, different forums, like the one that Abdul mentioned that I wasn't aware of, and I'd welcome sort of a better understanding from a board perspective through the committee about how this framework comes together, and if there's anything else that we could consider or support as an ICB to move that forward.
Thank you. David, perhaps you
I'm sure it's no problem for it to come to the Finance Performance Committee.
Okay, thank you. There's just one point I wanted to raise before we move on, which is, as we know, when the waiting list grows in total size, and you're saying about how it's over doubled since the pre-pandemic period, then as sure as night follows day, there's going to be longer waiters as the total number waiting increase. So I think, I'm not quite sure where it lands, Kevin, but we'll give some thought to this. So there's an issue then about the total number of people are waiting longer. The national target accountability framework requires us to essentially look at the longest waiters, whether that's 78 or 65 or 52. That in itself then potentially clashes against some of the inequality issues that we've looked at here, and also some of the clinical judgment issues that clinician may well say it's more important I see someone who's waited 40 weeks because of their circumstances than it is someone 78. So I think somewhere we just need, a bit like Jeff's point before on stroke services, if we look at the totality of a service and all the different dimensions to it and how they all come together, I think it would be good for Kevin for us to do that somewhere across those sorts of issues on elective wait, because this is a problem that's coming inevitably as the list continues to grow. Well done, thank you. Let's talk money.
Thank you, Chair. Okay, so we've got the finance report at month 8 in the pack. At the start of the year, the board will remember and have been monitoring a deficit plan throughout the year of an £80 million deficit by the end of this year. And that sat wholly actually within the providers, with the ICB breaking even. That plan was set after we set a 5%, so one of the most challenging CIP and savings plans that we've ever had to put in place. So there was 5% savings plans across the board identified. But even after doing that, we went into this year knowing there was another 70 million of risk in terms of stretch that would require us to deliver system-wide recovery plans. And I guess what this report is now showing, that those risks, although they've been there through the year, are materialising. We've seen it throughout the year in the position. But I think we've got to the point now where, you know, we are looking at a forward look that's really clear. We are not going to meet the £80 million deficit plan. Hence, in the committee updates earlier, the risk rating being increased from 20 to 25 because it's now certain and highly likely and highly material. So the 70 million stretch that we set was a very ambitious target, but we set out some ideas and recovery plans at the time around shared services, around GIRF benchmarking, driving efficiencies out, looking at the unfunded capacity and a number of things that we could do during the year. And I have to say we haven't been able to do that. We know these things do take longer, but we haven't delivered those things. And therefore, this is now impacting on our financial position. These are going to be formed as part of the recovery and transformation, and there are plans, obviously, coming together that will drive this out over the next period, but they're not ready for this year. So savings plans have also been are being delivered. So if we think about a 5% savings plan and across the providers, plus the delivery of savings in the ICB is around 300 million. So this isn't because we're not delivering savings, we are delivering significant savings across the system, but it's just not enough, and we have to be more transformational and doing it quicker to get to where we need to be. On top of that, we've been hit with quite significant levels, as we know, of inflation across CHC and prescribing that we didn't know at the start of the year, that and a high number of additional packages of care. So we're on a trajectory at the moment. At the moment, at month 8, in this report, we're 172 million in deficit. On a trajectory, if we continued in the current vein, it would be around 260 million. But during November, we did a replanning exercise to identify the potential to reduce that trajectory. And it would rely on a number of things, including really focusing on exit run rates. So we're looking at reducing that trajectory to 198 million by the end of the year. So we are planning to reforecast our position at month 9 when we get the next reports based on that position. That will be 49 million for the ICB and 149 million for the providers. So it's really essential now that we focus on the last few months on our run rate coming down so that can be met, because there's still that risk. The difference between our trajectory and what we're saying is still another 60 million of actions that we need to make sure we deliver, including getting the run rate down. So all of the discussions we've been having in the assurance meetings and with our colleagues have been around how do we focus on that, plus making sure that the 5% savings that we have done, that 300 million, is recurrent, because it needs to be as we go into next year. Otherwise, we are storing a bigger problem into next year. And I have to say there is really good progress on that in terms of the savings that are being made, and there is a real focus on that recurrent nature of it. So we need to continue that work in the last few months of the year. It's also going to be essential that the recovery plans that we were trying to implement this year absolutely embed and are in place and start to deliver from the beginning of April next year as we go into 24-25. So the focus on recovery and transformation is absolutely key. The position also relies on us being able to make sure that we work closely with our partners about aligning our costs across those packages between health and social care. So there's a number of conversations going on between us and our local authority colleagues about making sure that we are putting the costs in the right place, so that's between across both parties, but making sure that going forward we've got that right. So there's a number of discussions going on with our partners to make sure that we can do that work. What I can actually say is that this isn't about, you know, grip and control. We're having lots of grip and control in the system. We're pulling everything back. We're delivering £300 million of the savings, but it's just not enough this year. So unfortunately, it's not a great position to be making the board aware of, but it's a realistic position that hopefully people will recognise and have been seeing that risk maturing during the year. Happy to take any questions.
Any questions? David?
I mean, obviously not a nice read, as you said there, Sam, but I'm wondering what happens now, because the pictures was bad, it's getting worse. And, you know, are we likely to see any kind of escalation or intervention, or what's the impact of this position?
Yes, we are in discussion with NHS England. We have already got a recovery programme. It's about agreeing the elements of that and whether that will include intervention as part of it. So that's in discussion really for 24/5 in practical terms. We've already adopted all of the controls, etc., which is why Sam sort of said the grip and control side of it's more than well covered. And the discussion with NHS England is we're saying, look, we know where the issues are, we know what the solutions are, we don't need more analysis coming in with PowerPoint presentations, etc. It's actually about rolling your sleeves up and getting it done.
Aaron.
Thanks, Chair. So yeah, it is a sobering position that despite best endeavours and the efforts of all partners, we're still not able to turn the run rate around. The ambition for Q4 now is to get the run rate position at year end in the right place to give confidence that the 24/5 full year impact will look different than this year has done on the outturn position. It is an incredibly difficult set of circumstances. All of the agendas today have talked about areas of improvement and focus and potential investment and restructure and transformation. But if we don't take the opportunities in front of us now on grip, control, productivity and efficiency, we lose the opportunity to take forward those platforms in the way that we want to for our community. So really difficult discussions with provider boards, chief execs, chairs on commitment to the year-end run rate improvements, which we're putting forward additional plans on grip and control and vacancy control now to try and achieve that for year end. And I know we're talking with partners across the system this week and next week on a very difficult and different contracting round for next year, recognising the financial constraints. Again, engaging with our clinical operational teams within the providers to understand why we're having to do that and what the longer term ambitions are is a really critical part of success for next year. So working with Kevin on how we pull together the year-end focus, the grip next year, and then some confidence of the future under that recovery work is a key part for us in Q4, Chair, but full commitment from the provider collaborative board chairs and chief execs to get this in the best place we can through Q4.
Thank you. Noted. Angie?
Thank you. It was really just to advise the board that we had our provisional local government settlement recently. Government confirmed the 2-year settlement that they'd given us last year was to remain consistent. In doing that, they acknowledged the increasing demand in the system and the increasing acuity of the cases. They also recognise that the impact of the national living wage, not only on our workforce, but on the workforce of our social care providers in particular, would have a significant financial impact. However, in maintaining the settlement, there has been no additional money to compensate for those pressures. So that means that local government itself is facing continuing financial challenges. And that again will obviously be something that we will need to think about through the partnership. And there's going to be a significant leadership role for the executive to make sure that we maintain those constructive partnerships and do not end up just chucking the hot potato over the fence between each other. And that's going to be incredibly difficult when we think of the pressures that are coming from central government and indeed from politicians across the board to manage this. So it's sorry to add more gloom to the scenario, but I think we just need to recognise the difficulty of the situation that we're all facing and the importance that does emphasise for strong leadership and good partnership working. Thank you.
Thank you. Roy?
Just be very brief, Chair, and I won't comment on the actual report itself or Sam's explanations on the mitigations there and the issues that are remaining in regards to the cost pressures that we are describing today. For me, it's to say a big thank you to the teams that have been working on this. I think it's really important that this recorded, that we say that, because there's a huge amount of work that's gone on in the background, not with the executive team here, Aaron's team within the acute trusts as well, and of course in local government as well. So I think it's for me to say a huge thank you to those people for that work, for the continuing work that's going on ahead. And Sam's point about the recurrent status, I think, of the position is very well made, in that I think, you know, this will be an ongoing pressure for next year, clearly in 24-25. I think it's really important that we continue to maintain that recurrent status that we've achieved, and the work, I say, that's going on within the trust is well appreciated, and the local authorities as well. So the BCF funding, of course, will come under discussion as it has to, but again, difficult discussions, but grateful that we're able to have those discussions, I think, and that's the purpose and intent of this board. Thank you.
Thank you. Okay, so this is the first moment that we've had in the life of the statutory life of the ICB, at which we're advised correctly and professionally that we're in breach of a statutory duty, and will be at 31st of March. It's a bad position, as colleagues have said. It damages us. It's a disservice to the people that we serve. I'm talking about the ICB position within the overall system. It's highly frustrating and disappointing. We've discussed previously all the reasons why we're here, and the legacies and all of that, but this is our lowest moment since we started. We just have to do all the things that Sam's advised and that we've discussed previously to make sure this doesn't repeat itself again for us next time. System Recovery and Transformation Programme leads us into that nicely.
Thanks, David. And sobering conversation about our finances, and I hope by closing off this section of the board papers I can perhaps lift us a little bit as well in our outlook. I think both what Sam's just described and what other colleagues have said during the previous agenda items, when I'm working with our colleagues across the system, I try to keep things relatively simple if I can for them. We talk a lot about the grip and control element of what we do, and we also talk a lot about the cost improvement requirements that we all have. And we have without doubt seen improvements in both of those areas, as Sam and others have alluded to already. And I am thankful and congratulating our staff for the approach that they've been able to focus on this year to see such improvements, because it's not just the people around this table that have been doing that. I think the third area then really is about the models of care. And we've really spent a lot of time through all of these reports this morning articulating and bringing out the consequences of the models of care being as they currently are. We've heard and jotted words down like this is decades old, this is historic, this is culture, these are legacy issues. And all of that's true. But the work that we've been trying to do, I've been focused on since I joined the ICB, is if those models of care don't work as effectively, both for outcomes, and Jeff, you mentioned some of that earlier, for our population, but also to use our financial resources in a way that's expected of us by our regulator, then how do we actually start to turn the oil tankers round? The paper references some of that work, and I took on board what Jim was saying as well, David, around bringing more granular detail here. And it may be, David, if you're supportive, that as we get into the end of Q4, we might want to timetable a seminar where we can go into a lot more detail in relation to what you can see under, I think it's 2.6 in the paper, is there's 3 arms to the work that we're doing. There's what the new clinical models will look like, and that's acute. That is our community and care models, and it's also our mental health, learning disabilities and autism work. Now, within those 3 areas, nearly everything that's been talked about this morning in the board paper is covered. We are also linking that under David and Sarah's good governance around clinical effectiveness. So what does all of those words in those 3 areas, those 3 key clinical models, what will clinical effectiveness look like in those areas? What will it do to morbidity and mortality in Lancs and South Cumbria? And how will we start to push some of our ambitions in relation particularly to the areas of deprivation and the things that we've talked about as well? And the third area is that we see improvements in our regulatory performance, so both what the CQC say about our organisation and our providers, all of those regulated by the CQC, and what do NHSE say about how we use our resources and how we push our innovation and our responsibilities as far as we can. So there's a lot going on. We've shifted to bring in ICB colleagues, and that's commissioning, contracting, professional leadership, alongside our provider collaborative colleagues. So we've got one set of schemes that are prioritised in relation to those three arms that I've just described. We're getting into real granular detail. We've stopped having 1,000 butterflies fluttering around us where we're putting investments into each of them. We're evidence-basing where we spend our money and what are the outcomes that we're expecting to see. Now, I am not just promising jam tomorrow. We are starting to see some real impacts of that work, but I don't have enough time in the agenda today to take everybody into the granular level of detail. But I do want to lift people with that work is underway. Finally, David, I just mentioned we had 2 events in November where we brought some clinical leaders together and some frontline colleagues, both from an acute and a community perspective. And there is real energy and positive feedback from the colleagues in that room. People like myself who are relatively new to this system were asking, how does this feel to you now compared with the work that you've done previously? And Aaron was present alongside myself and others in those some of those sessions. And the clinical feedback that we got was, it feels different, it feels purposeful, it feels more logical and structured, and it feels as if this is really going to be outcomes focused. So a bit of jam tomorrow, a little bit of pragmatism about what we're seeing, but a real commitment that my exec colleagues and myself, we are really focused alongside our provider colleagues, our local authority colleagues, as well as Angie's referred to, a really good session with our executive colleagues this week. We're really committed to bringing some outcome changes to these forthcoming boards. So I'll pause there, David, happy to take any questions.
Thank you. So there's so much substance now going into these programmes that we can't really add much value at this stage until we get into the detail in talking about them. We'll take any urgent points that people need to make now, but I don't think we'll really add value to the work by trying to get into the depth of the programmes at this point. David, do you want to go?
So just very quickly, I mean, I think just to understand that the workshop on the 17th of November, where the leaders from the trust, the providers came together with some of the executive members of the ICB, was a really good meeting. We identified a number of common priorities we've all agreed we will take forward and put some pace into those. And an example of that will be that we need to centralise the specialist vascular surgical services. We've agreed they need to be on one site. We've agreed now there is a timetable where we can see that's going to go to the clinical advisory group in January. We've been in discussions with the regional team about taking that through the stage 1 of the NHS England assurance process for when we reconfigure services as well. Is going to go to the regional clinical senate as well. And once we have moved that one forward, we can then have the understanding that should that move to, for example, Lancs Teaching Hospital, we can then understand how we utilise the resources we have, which brings us back to the estates paper we've discussed already, because there will be gaps elsewhere in the system. We have other services such as urology and head and neck, again, where we need to reconfigure on one site. So we're going to be taking that forward, but there will be a number of opportunities as we move this forward. But the work we want to do is we'll try and do that at pace as we move forward.
Thank you, David. Okay, to move on. Oh, Angie.
Thank you. Just 3 quick points. The first, this is really important. At the County Council, we've changed our practice model for children's social care. Our looked after children numbers are going down and they're staying down, and that's triangulated through the data. And we're not having people using our NHS parlance readmitted into the system. So there's significant opportunities here if we can make it right. I think my challenge to Maggie would be, you need to come back and tell us what you need from the board so that we can support the executive to have the capacity to manage this and not get constantly sucked into some of the immediate pressures and requests, particularly of NHSE and the region. So how can we support with that? I think there's something for the providers in this, because clearly the providers will need to balance their own budgets, and we've had that conversation, but they're going to have to go further if we're going to release money for that community reconfiguration. So how does the board help to empower the providers to do that? And then the third question, I think, to challenge the board on, and you do refer to it in your paper, is does the executive across the system have the right skills and capacity to make this change? And if they don't, and I suspect the answer is no, how are we going to create that and bring those in? So I think that's what I would suggest to you. I think we need to come back clearly to the board about what support you need from us to make this happen. Thank you.
Yeah, I'm not sure we can give a lot of support in telling ministers, the Department of Health and NHS England to mind their own business, but I understand the point.
If I could just come back on that slightly. I've worked in systems before, Angie, when I've dreaded going into intervention because of the grip and the control and the SIP and the demonstrations of improvement have been sorely lacking. And so it's been really hard to sit in front of people and try to make something more positive out of dire situation. But here I think we have got positive things to say about the collective efforts of all our people. We can see that in some of our benchmarking performance. We've got an area of real big structural changes to make, and having more support from those who've been in this area and working in structural changes, new models of care, is something that I welcome, not fear. So I think I'm not looking at some kind of intervention in that way in a totally negative vein, and I'm saying that to the colleagues, particularly who are leading services, that they don't see this as a punitive step that we may be entering into, but we take all of the opportunities that we can along that way as well, David.
Okay, thank you. To be continued. Well done. Now, it's an outrageous ask of the board. Can we sacrifice the short break? If we finish the meeting in the next 20 minutes or so, is that okay? People content with it? Anybody needs a break, that's fine, we'll stop for it. Are we okay? Maternity, please.
Thank you, Chair. So the paper in the pack is the paper that we deferred from before Christmas. So just a couple of, one main thing to update. Since then, the CQC report for Lancs Teaching Hospital was published, and they requires improvement for maternity services at Preston and good for maternity services at Chorley. So I just wanted to update the paper with that. And I won't go into the paper in too much detail because I'll leave time for questions. But when I wrote this paper, what I was trying to do was, I suppose, ensure that board really understood the assurance processes that we have to deliver around maternity across the system and the role of the local maternity and neonatal system, which does sit within the ICB now and sits within the team that work with me. And really I was looking to give board assurance that in terms of the national ask around maternity services, that we were doing everything we needed to do to have that oversight and that assurance and be able to report into quality committee and then up to board. But I recognise in doing that it's in some ways quite a processy, dry paper, and board might want to see more of the softer side of the things we do on maternity. So I'm happy for future reports to take any feedback on what you'd like to see. Overall, what I would say is maternity and neonatal, particularly since the issues at Countess at Chester and the Lucy Letby case are everything's under scrutiny. We've talked about that a lot today, but maternity services and neonatal services more than anything have had now a number, unfortunately, of nationally reported issues. I don't want to use the word scandal, but areas of really, really failures across patient safety in those units. And obviously there was the Morecambe Bay initial report on our patch, and then since then we've had Kent, Staffordshire, and now there is still Donna Ockenden is in Nottinghamshire as we speak now, and I think early reports of that is there's going to be very similar findings come out of that system. So it's a real concern for everybody. In every meeting I go into with the Chief Nursing Officer, she will say maternity is her big worry and continues to be her big worry in terms of assurance. So it is a real challenge. I think in terms of us as a system, I hope what the paper does is give you at least a level of assurance that we have got teams working on this, working right across the system. They've got that oversight. And in terms of our maternity units, and Aaron might want to come in terms of Hospitals Morecambe Bay, they have done a lot of work. That unit is not the unit it was all those years ago. And actually, I think I'm correct, Aaron, that the national team are actually in the trust today doing that review of maternity services, and we're very confident, hopefully, that will move them out of the national programme, which then means we've only got one of our units who remain under the national programme. And the last thing I would say in terms of that sort of stuff, if you can imagine if you're a midwife or a nurse working in a neonatal unit at the moment, how difficult it is to get all the negative publicity, because obviously it's right that it gets the negative publicity and it's horrific, but actually for all the things that go wrong, every day, day in, day out, midwives will be working to excellent standards. People will be getting a good pathway, they will be getting good care, and babies will be delivered in a very safe way. And I think I would like to put on record that overall in our system, we have excellent midwives and neonatal nurses day in, day out doing the very best they can in very challenged thing. And I also want to pay homage to all the teams, because Craig talked before about the flood that happened at BTH just before Christmas, and they had to evacuate children's and maternity wards, and the whole system rallied around that. Midwives from across the system rallied and did that in a safe and effective way. So I think it's important we recognise that as a board. So I'll pause there, and I'm happy to take any questions, and we do get regular reports through Quality Committee.
Thank you. Jim?
Thanks. It is a helpful update. The thing that bothered me when I read it was the year of the 2022-23. I think it's Q4 figures for Blackpool Teaching Hospital, where they got 2 out of 10 on the in terms of achieving compliance with safety actions, which scared the life out of me, frankly. And hopefully it's moved forward since then. And I'm just wondering what position it's in now, and whether we can have any assurance around what is going on to make that a safe place for mothers to go.
Yes, so I will find out for you, Jim, the actual where they've moved in terms of, numbers out of 10, but I can assure you that since that finding, our lead midwife goes in there regularly. There is an improvement board, and so they are definitely moving in the right direction, but I'll come back to you with the specifics of if we were going in and doing that review again. And actually, also, each of the maternity units have got to do their CNST returns this month, and they also come to Kevin for sign-off. We've had one, so we will be able to report back the exact numbers as well from that point of view of where each unit has got to.
I've got David next, please, and then Debbie.
Sarah, I'm just wondering if you can give us at some point in the near future an update on the independent advocacy service. I believe Lancashire is part of the pilot following the Ockenden report. So it'd be really good to hear about that. It's all about the voice of women and birthing people and them sharing their experiences. So it's good to be part of the pilot. I have a concern which would be really, I'd welcome being addressed or discussed, which is about the independence of the advocacy. So having an independent advocate who is employed by and works within the NHS is challenging to me. And every other form of statutory advocacy has that outwith of statutory services. So I'm perplexed by it and would welcome some kind of assurance about how we'll see that independence of that advocate demonstrated. And I welcome hearing from them about what we're learning from women and birthing people.
Yes, please.
Yeah, so we are part of that pilot, and actually we're one of the only systems in the country who's managed to recruit into that post. So and we had a discussion about this at Quality Committee, so it's actually been put on hold a little bit nationally. However, because we've got somebody in post, they are actually doing some of that work already, and we had a very powerful patient story at Quality Committee. Your colleague came and raised the same concerns of you about the independence of the advocacy. So, I mean, that's down to the national way it's been rolled out nationally, David, so that's how it's been implemented. So I suppose, I think I can give you assurance in terms of we've employed somebody, They're a midwife, they're doing some brilliant work already, and we had a real example of that at Quality Committee in terms of a story that came through to show the benefit of that individual. They are doing the work. I take your point about the independence, and I will feed that back up through the maternity kind of structures at NHS England and think about how we do that. And I'll have a conversation with you about how, because obviously I can sit here and say to you, well, from my perspective, you know, she's got the independence and the autonomy to go and do what she needs to do. It doesn't change the fact of what you're saying, that isn't normally how independent advocates are employed. So if we maybe have a conversation about that and think about how we can put a bit more autonomy around that from your perspective, and have to take some advice from you on that.
Thank you. Debbie?
Thanks, Chair. It's around engagement and involvement to support and underpin some of those very necessary service improvements, Sarah. So I know, thinking back to Central Lancs, which I'm closer to historically, there was a really amazing Maternity Voices partnership that was supported by the CCG, really proactive, did some amazing work that led to service improvement within Central Lancashire. I'm sure that there will have been similar structures, and I'm just wondering if you could give us an update and a view really about whether we're engaging and involving people and communities in the service improvement as well as we could do, if you feel that there's more that we could do.
Yeah, so and I think obviously we're the ICB, so our role is across the system. So each of the maternity units will also be doing, and the maternity teams, both community and acute, will be doing engagement work in terms of how they work. But we still have the Maternity Voices partnerships that is still running across the system. So they are doing that ongoing work in the way that you're describing. That hasn't gone away.
Thank you. Jeff?
It's just a thought about what happens when this is all over. And human nature is that actually when you're under the spotlight and you're going through a process, things get better and everyone's switched on. My now deceased first partner, when I was a young GP, said to me one day, when I was being a bit cocky, he said, "You're only as good as your last patient and your last mistake." And I think, so you think you're really good, you are really good, you are doing everything right, and then the spotlight turns off and things slip again. And that's probably relevant to all clinical services, but I just think this is particularly relevant to maternity because it's so high risk that we need to think afterwards, how do we maintain the progress? I think it's absolutely critical for maternity personally. I was part of that stuff in Morecambe Bay, wasn't I? And Kirkup, I was part of the recovery. I can't remember what we called it now. There's some really good stuff done, but you can slip again. And my anxiety is that we don't just fix it for the moment, but we fix it forever.
Thank you. I think that the Appendix 1, so I know that you come back to us on saving babies' lives on the maternity incentive scheme, as you recommend. When looking at the Appendix 1, I mean, we've talk here about, whether it's in the performance report or elsewhere, we talk about variation. And how what we do when something in one part of the patch is very different than another part of the patch, whether it's an access or outcome. What Appendix 1 shows us is that is a variation, looking at the Morecambe Bay one, Aaron, within the one organisation you've got very different. I look at the East Lancashire one, it looks like one organisation. You can imagine there's a clinical model and there's ways of working. If I understood correctly what you said in the intro, we've got Preston at requires improvement and Chorley at good. So there's an issue for us when you've got such a stark, when you've got such a stark difference within the organisation. I'm sure, knowing a little bit about the Westmoreland one, Aaron, where we've talked before about some of the staffing issues there, you can see it. But this variation within the single organisation is an issue that we haven't really focused on before, and I guess the boards would do that. The Preston Chorley thing intuitively feels the wrong way around to me, but so there's a particular set of challenges and issues in that. Okay. Move on. Freedom to speak up, David.
Yep, okay. 2 more papers till we finish. So Freedom to Speak Up, we've covered Freedom to Speak Up quite a bit during this meeting already, and just to highlight that Freedom to Speak Up is really important because it gives our staff a safe place for them to kind of share concerns about safety or quality or the behaviours of other members of staff. And I'll take the paper as read, but just to a couple of very quick highlights. We've got 3 guardians, they've been trained. They've now been trained in mental health, first aid training as well connected to regional national networks. We set up a SharePoint. We've got 6 Freedom to Speak Up champions who've also undergone training as well. The guardians are part of the ICB induction programme. As part of the Freedom to Speak Up month of November, we had some staff briefings, which again we spoke to all our staff about freedom to speak up. Jane and I joined monthly meetings with the Guardians team, and we have reached out to some of our larger providers across the ICB geography, and we've undertaken a baseline assessment, and we're going to have a Freedom to Speak Up event for their Guardians in the spring. And I think one thing we will include, in fact, is a focus on maternity and neonate in view of the Lucy Letby issues. I think just one thing just to flag up is that when we benchmark ourselves against other ICBs, we probably have less resource for our guardians than others. And also we are concerned about the fact that NHS England as yet still have not issued any guidance about how freedom to speak up issues in primary care will be managed from April of this year. Silence, unfortunately, is rather deafening. And then the final thing in 210, there are just some kind of general themes coming from 12 cases we've had to date. So there we are. Happy to take any questions.
Any questions, please? Content to receive the report. Thank you. Well done, David.
Did you want a question?
Only a really quick point is about it's really the going forward bit about assurance around really how we can use pulse surveys and things to make sure that people feel confident about being able to raise concerns. So I think great progress on the process, but it's really just how do we get the assurance around that people, if they do have a concern, hopefully what people would do is actually raise things in their own area, but if they do feel the need to raise concern, how do we actually get that assessment of the level of confidence?
I think that's gone into the questions we're asking our staff in the pulse surveys.
So can I just add something into that? That's almost the task of the audit committee in a sense, because we're supposed to look at the effectiveness of it, and Mercy Internal Audit Agency are going to undertake the work Sheena's talking about. That's what I'm hoping the purpose of that internal audit will be. So that will give us a feeling for the extent to which we are assured or otherwise about how effective the system's working.
Okay, thank you. Happy for me to move on, David?
Of course.
Thank you.
The next paper is a paper on the impact of the General Practice Improvement Programme. And this is here because we've been asked by NHS England to bring it here. As you can see in 2.2, in fact, NHS England issued a further publication on recovering access to primary care in May of last year. That's 8 months ago. And part of that was around, in year 1, 4 key areas, which you can see in 2.2, empowering patients to look after their own health, implementing modern general practice access to tackle the 8 o'clock rush, which includes the telephony, which Kevin mentioned, building capacity because we've got a multidisciplinary workforce now in primary care, and also trying to cut the bureaucracy between primary and secondary care where they pass off tasks to each other. So what's happened so far in Lancashire, South Cumbria? We've got a number of different phases. We've already got 36 of our 198 practice signed up to this, and all the remainder will be signed up by later on this year. Nationally, they've managed to come up with some outcomes which do reflect fairly positively, as you can see that in 4.1. Improving continuity of care and releasing GP and admin time, for example. Though you can also see in 4.2 there's almost been a doubling of online consultations. So rather than, many of you may probably use this, rather than trying to ring up at 8 o'clock, you ping off your email request into the practice when it opens at 8 o'clock as well. So we do need to be mindful that demand increases if you increase the number of ways patients can access primary care. To be honest with you, I can go through all the figures, but the fact is that it's too early for us in Lancashire and South Cumbria to be able to determine what the impacts are. Other than that, the fact we've probably got some practices who are what was best described as early adopters. What they do is they like the fact that they now have permission to change, and I think it's really important to understand that primary care can be really innovative, agile and nimble when it comes around to change. So I think we'll see a number of positive changes. And I think what we'll see is some of the challenges will come as some of the later practices come on board, where perhaps there have been some quality issues and those what's affectionately described as laggards. So in conclusion, a little bit too early to say how things are getting on with regard to definite, tangible metrics of improvement, but nevertheless there's a lot of encouragement that this is being adopted by primary care, and they are very happy to take this forward. I'll pause there.
Thank you. Innovative, agile and nimble, Jeff.
Yeah.
I think there are some really great people and practice that do that, but again it comes back to that variation. Some people aren't. Sorry. Do you want me to say that again? Yeah. I think there are some really good individuals and practices that are really right at the forefront of innovation and getting it right, but it comes back to the variation, and so there are some practices who are way behind the curve, and that's one of our challenges.
Thank you. Debbie, then Sam.
Thanks, Chair. So welcome the report and the update. Completely take on board. It's obviously early days, isn't it? So I look forward to it coming back and being able to demonstrate the impact and the value added. A couple of points just really that I'd welcome being considered. I'm wondering if there's a way to encourage and support those primary care practices who could benefit most from this to take up the service offer. It's putting it very sensitively. I'm just a bit concerned that those who are most likely to step forward, because it is a voluntary scheme, are those that perhaps are at the higher echelons and are more open to innovation and continued improvement, rather than ones where we know it could make a significant difference and improve the performance and the service that the patients receive. I think it's really important around the baselining that we understand what the baseline position is. So on some of the performance indicators, it was quoted, for example, that patient satisfaction 6% or in the highest 6%, or it's improved by 6%. For me, I would like to understand where they start from and what the added value is on a practice basis, because if they're already in the highest quartile anyway, if there's just a little bit of a nudge, is it really the best use of investment and has it actually made the best added value? And then it's the telephony point as well. So we're saying that we don't have access to telephony data, given that earlier conversation we've had about how important it is that people can get through quickly, that they receive a great service. Hopefully that's something we can pick up on. And finally, we mentioned under practice and detailed patient feedback 9.1, there's no local feedback mechanism. I'd really welcome some insight maybe from the ICB's engagement and involvement team about how we could support around that to be able to capture the information and to feed it in as part of the evaluation and assessment of impacts.
Thank you. David, do you want to come back?
Yeah, so thank you for those points. And unfortunately, it'd be fair to say that some of the data is simply not available even nationally. They've set up the programme, but they haven't set up the metrics necessarily. I do think your point about those that benefit most, we have, as we described earlier, a number of, and you well know this very well, of practices which they have struggled, and maybe we should rather make this voluntary. We should perhaps kind of recommend that they are involved in this sooner rather than later. But I'll pick up the issues particularly around that 9.1, the feedback from patients as well, because we need to ensure that we're getting something. And there's thank you for your offer.
And Sam?
Yes, just quickly, I just had a flick through this again after listening to the patient story earlier, and it is about metrics as well, and just not to lose it. I'm just wondering, there are some things that came out in that patient story that doesn't matter how many numbers we have coming out, these metrics, which are the ones that are going to capture that we've made a difference. So when we think about it, we could count the number of triage and navigation or whatever or numbers, but actually how do we capture, maybe it is in some of that satisfaction survey, but how do we really know we're getting customer service right, that some of those things are right for the, because I think, I'm not sure you'd do it all through this, so it just might be something to think about, David.
If I may, so very quick, so I think you're right, Sam, and in many respects it comes back to a point made much earlier by Jim. I think it was Jim you mentioned about having access, or at least seeing some metrics for primary care. Was it yourself or Roy? One of the committees report out on that. And I think, right, we need to pick out some metrics for primary care which are actually meaningful. We have, let's not forget, we've got 198 practices, but we want to have some measure of kind of what's going well, what's not going well, and where maybe we need to focus some of our attention. Thank you.
Thank you. Good. So, the report sets out a number of recommended next steps. David, in 14.1, we recognise it's helpful to have the flavour of this now, even though we recognise that it's too early to draw the conclusions, but the recommendations supported. Thank you. Brings us to the end of the agenda business. I'm not notified of any items of any other business. I don't think, Kevin, there's anything new from a risk register point of view that we haven't got there. They're sort of continuing re-evaluation of the risks and the relative risks. In the example Roy gave in committee will continue through the committee mechanisms. As we've reflected from the very start, and the theme through all of the discussions today, the system's under immense pressure, has been for a period of time. These things always get more exacerbated in the winter period. What we've seen today in the reports and evidence in the discussion between us that the system's responding to those pressures remarkably well. People doing great work in the service of the patients and families in front of them. Our job here is to ensure we really try and create the conditions in which people can operate most effectively and in a most supported way in the front line, and we need to continue to apply that test to our work as we go forward. So thank you all for the coming. Thank you for the contributions you've made. We meet again on the 13th of March, and we're changing the formatting of the day a bit, right? Yeah. So from March onwards, the meetings will start at 1 p.m. The public meeting. Thank you very much. Meeting closed.